For example, John Williams to read the day rate of birth, considerate the ethic of Gorbal. What's the cynnes I cyfarfod y bwrdd yma. Croeso mawr I Gareth Westlake a Louise Scanlon gyda ni am y tro cyntaf heddiw. Morning everyone, I'm John Williams, Chair of the Board of Swansea Bay University Health Board, board being the governing body. Warm welcome to everyone and to our guest Louise Scanlon with us for the first time, and to Gareth Westlake, who is deputising for Matt John. So the board is a strategic population health body with responsibility for the population health and well-being of almost 400,000 people across Swansea and Neath Port Talbot. And you will always hear the board talk about different aspects of population health and well-being. We also have a statutory duty in respect of health protection and public health. Now, along with the other health boards in Wales, Swansea Bay is one of the largest public bodies in the UK. It's important to remember the scale of that. We have 13.5 million, and we are responsible and steward for 765 billion of public money. And then through me, the board is also accountable to the Cabinet Secretary for Health, Jeremy Myers. And the Cabinet Secretary has set the board and organisation some organisational objectives this year, and we'll hear more about those from the Chief Executive when Abby presents her report. And of course, we use Abby's Chief Executive's report to frame the general discussions that we're going to have. So the board, being the governing body, is the highest level of decision making for Swansea Bay. And we have regular bi-monthly meetings, of which this is one. So therefore we are covering the breadth of our agenda today. We are committed to openness, transparency and accountability. And we're constantly looking at ways in which we can build on that accountability to the public. And we are developing our AAA report, Alert, Advise, Assure report from our committees to the board, because committees do such heavy lifting for the board. And we are also developing an integrated finance and performance report. These are projects that we'll be developing in year as we aim to improve the way in which we account to the population for that 1.765 billion. We are bringing in another new feature today, and a planning and partnerships agenda item. This is under the section of the board's role around strategic direction setting. The board has to be future focused, and as I say regularly, the decisions the board makes around strategy and planning will have an impact for 10 to 15 years to come. So we've got an overarching paper on all aspects of planning and partnerships today. And I think it's the first time the board, the full board, has taken a look across the planning and partnership landscape. And it also sets out the approach to the way we commission. Another item under our strategic direction setting is our strategic equity plan, because within our 400,000 population, we will have different groups, different communities with different and differential health and well-being needs. And we have to meet those needs across the population. Clearly, research and innovation is of fundamental importance in healthcare. They drive evidence-based improvements in care and outcomes. So we are working on a regional strategy for research and innovation with Hywel Dda University Health Board. And in the meantime, we're looking at a bridging strategy whilst that work is underway. The board is also responsible for setting the strategic risk appetite for the organisation and overseeing strategic risks. And throughout our discussions, you will hear us referring to different aspects of risk assessment and management. Now, as well as looking to the future, the board does have a very important role with its committees of scrutinising delivery against in-year plans. And there is a section on the board agenda around that. As I mentioned earlier, further examining the report sets out the excellent progress we're making in planned care, the challenges we're facing in other aspects of service delivery, and then the ways in which we intend to meet those challenges. So, and this time, for the first time, the board is taking a paper on general dental services. This is part of a rolling programme around primary care. And again, this will be the first time the full board has taken a look at primary care services. Again, a really important part of our agenda. Given that the health board is workforce led, as 80% of our spend is on staff, we've got a specific section on people, and we are really going to focus today on the results of the All Wales Staff Survey as they relate to us and the implications for us as the governing body of this health board. And that also links with the role that the board has working with our staff to set the tone and culture for the organisation. The board is clearly required to maintain good governance, and we always have a weighty section on this, and that's true today as well. We've got a number of updates in respect of really important special programmes around different maternity and neonatal services work. We're also bringing in a new performance and assurance framework, which is again another way in which we are improving and enhancing our accountability. And we're taking a look at how we conducted board business last year, what did we take in committee, what did we take in public session, and then we will be looking to learn for the future. So a very important, very weighty agenda again today. So I'll turn now to that agenda, and we have apologies from Andrew Mutlow from Llais. Llais is in transition in terms of our regional director. I think that's right, isn't it?
Yeah. Just to add, John, we have had confirmation from Llais of the interim regional director, and we're making contact. They're due to start the first week of June.
So hopefully they will be able to be with us at the end of June. So Matt John is on leave, and Gareth, as I said, we've got new deputising for Matt, and Jill will be joining us, Joe Richardson, this afternoon on Teams. And we do have Nuria with us on Teams this morning. So any other apologies come through? Very good. Thank you all very much. So we'll turn then to declarations of interest. The board does maintain a register of declarations of interest. So this is about any declarations relating to the agenda for today. Does anyone have any such declaration? No? Thank you very much. So then we will move on, Abby, to your chief executive report.
Yeah, thank you, Dan, and thank you for the introduction that you've already given to this report. So I will take it that people have read the report, but there are 4 things that I want to draw out from the report. 3 of which will actually come up as part of the other agenda items as we work through the agenda. The first one is to pick up on the maternity and neonatal services. Colleagues will be very aware that since we last met, Llais have published their report on experience of women using our maternity and neonatal services. And that is being fed into the independent review. So we understand that Llais have shared that report and the detail of the report with the independent review so that they can take that into consideration as part of their engagement strand. Colleagues will be aware that that was a difficult report to read. It did reflect some poor experience and poor outcomes for the women who've used our services, and to put on record our apology to those women who didn't get the care and experience and outcomes that we should have provided to them, and that is important to recognise. For some individuals, small numbers, the impact will be devastating and life-changing, and we need to acknowledge that, and again, repeat our apology to those people. In terms of others' experience, some others reported experience where the outcome was actually positive, but the way that we provided care was not consistent with our values and behaviours in terms of compassionate care all the way through their care pathway. And in summary, Jan, the themes that have come through that are consistent with what we've been hearing from the independent review, what our own information has been telling us through complaints and concerns. And I know from the visits that we've done that the staff are dedicated, committed, hardworking, and want to do the very best they can every day for patients. And we are improving things. But Liz will come on in terms of her report to say what more will be doing, because we know we still need to do more. We are setting up a new overarching group that Liz will chair, and we are feeding back the information we're getting from the independent review as we go through the report. And just to say that tomorrow we have a session with the chair of the oversight panel and some of the colleagues who are part of the review and the clinical reviews. They're meeting with the exec team to give their emerging findings feedback to us, and so that we can consider those in advance of the report coming through. And that's really good practice. And again, we're not expecting to hear anything that's a surprise to us, but we're just working that through. So I wanted just to flag that. The second thing I wanted to flag relates to mental health services. So colleagues will be aware that we have commissioned some external special advice to us to provide us a bit of independent expertise in relation to our mental health services. I just wanted to report on progress, really, that a number of things have happened. We've previously referenced the fact that the Welsh Government has recently published its with mental health services and suicide prevention and self-harm. That is really helpful to us in terms of the timing of that, because it provides a framework within which we will continue to develop our services. But just to give you assurance that the programme of work that we've got in frame, both in terms of the immediate things that we are actioning, the interim solutions that we are progressing to address the concerns we've had around particularly the estates in which we're providing care. And then finally, the permanent and longer term solution to where we provide services and our service model is progressing. We have plans for to bring that back to the June board meeting. We're having a special board meeting for accounts and to take this item, and we're on track to bring that back to the board as part of that work. So just wanted to thank exec colleagues and the service group for leaning into this in terms of making sure that we're actioning the things that we need to do quickly to get the improvement and traction that we need. And then the two final items I just wanted to pick up, Jan. Again, when we come to the performance report, Deb will talk about the work we're doing to improve emergency and urgent care, and some of the developments that we're taking forward at the moment. We know that it remains a service under pressure. We know that it remains an area where staff are experiencing pressures, and we are meeting with them regularly. Both Liz and Deb have had some support going in there, working alongside staff. And we continue to get feedback from the group and colleagues who came to join us a few months back now in terms of sharing their experience. So when we come to that item, Deb can give you a little more detail in terms of the update on where we are. And then the final thing, Jan, you mentioned, the Cabinet Secretary has set out standard set of objectives for all chairs in NHS Wales, which is set out for you in my report. We've got some local domains specific to Swansea Bay that reflect our position in terms of those areas where we've had escalation and the things that we've identified where we want to make further progress. And of course, reference to the new joint committee we've got with HALVAR. And we know that the Cabinet Secretary is very keen that we make progress, is seeing us as a advanced party in terms of making progress around this model of working across health board boundaries, and we'll touch upon that as we go through the agenda as well. Jan, I'm happy to take any further questions that colleagues may have, but those are the only things I wanted to bring to the board's attention.
Thank you, Abby. That's a very detailed, rounded update in terms of our agenda and wider issues. So, shall I open it up for questions, please?
On another part of the report, you mentioned that you're working with the Regional Partnership Capital Board to develop this unit for specialists, complex learning disabilities. I was just re-asking, is what the kind of, it was great to see, what's the timescale for that opening? And is that meeting new demand, or will that enable the health board to bring people back from, out of county placements back home to placements within the region?
A bit of both, but mostly the latter. So we know that we've got inadequate provision at the moment in terms of the physical environment and the right service models to meet some of those needs. So it's predominantly the latter, Pat. But we bring the business case through to the board as we develop. It's come through the Regional Partnership Board. It's complex because it's a collaborative piece, and obviously we are the regional provider, so we're also having the conversations with the other RPBs. But it will enable us to bring some of those patients who currently we can't meet their needs because we haven't got the right kind of care environment, and we would expect to be able to bring some of those patients back. There's a lot of focus and attention on this at the moment at national level. There's a strong family voice about homes, not hospitals, which colleagues will probably be aware of. And we know that we have got too many people who are too far away from home, and that's part of our learning disability modernisation programme as well. Ria, I don't know if you want to add anything else on that.
No, just in terms of your question around timescale. So again, we'll have to test that through the business case process. So when the business case comes fully to board, there will be a proposal in there. Typically, these types of schemes, I can't remember, is it going for a SOC or BCFDC? BJC. So that simplifies the steps in the process. So it's kind of a one-stage business case. So once we get sign off, then we can proceed to the formal kind of construction process. I think Darren's probably got a bit more background on that.
Yeah, thanks. The management board considered it recently. The cadence of this is through PFC next month. From on to board then in July, so you'll see a full sight of the BJC and the prior consideration. Obviously, PFC can scrutinise as well. It's a circa £10 million case. We've had the fees funded, so it's positive in terms of that, but we obviously need to go to rate governance. And from a revenue perspective, there's a modest saving in this as well because of the reconfiguration of the service models. It presents us with a really strong opportunity for our residents, but also the finances are working through well at the moment, they've been subject to scrutiny. But I can confirm the build timescale separately once we've gone through some of that.
And just for public knowledge, BJC is the business justification case. It's one of two approaches through which we secure capital. It's a shorter process in its length, but it requires us to have gone out to tender and get all the costs known in advance of submitting the business case.
Pat, you happy with that? And to take it to the PFC. And Hazel, can we just do a short note out for the board, just explaining the two ways in which we can aim to access capital? That would be really helpful. Thank you. So I've got Keith, then and Louise. Keith, please.
Thank you very much for the report, Abby. It's very clear. I had a question about the update on mental health and learning disabilities programme, very helpful annex that's attached. In terms of assurance around that, it would be very helpful to see some more firmed up timelines against that rather than the rather vague statements that are in there about timelines at the moment.
Thank you for that, Keith. We will bring that back as part of the report that comes to the board in June. In particular, the re-provision and our solution to the interim is, as you can imagine, there is no perfect solution because we would have found it. And Melanie Walker and Narissa are working through the detail of that with the service group to work through what's our best option and line of path to get there. And that will give us some of the timeline in relation to that. But take your point for the other things where, for example, we know we're commissioning, I think we've got the tender back for things like the ligature assessment that we need to do, where we need expert advice in. I know where we are in the tendering process of that, but we can give you further clarity. We'll make sure when the report comes to board, we give you all of the timelines.
That's really helpful. Thank you. May I just follow up with one further point on that? Could that report, when it comes back, also look at the consequences of things like closing the surge capacity in terms of, for example, the number of people being placed in private sector beds a long way away, and the delay in beds being found for detained patients?
Yeah, we will definitely do that because there is an impact, and we are tracking that very closely with the service group, but we can bring that as part of the impact of that change. Yeah, that's helpful, Keith.
Thank you very much.
Thank you, Keith. And Louise, please come in.
Thanks. Yeah, I mean, it's been a little while now since the two nurses came from emergency care. And one of the things they said was it didn't feel safe. There was an issue with security and some of the patient feedback related to safety. And I just wondered now whether the security situation is kind of resolved and permanent rather than a sort of temporary, because I appreciate that that can be quite difficult.
Yeah. Deb, do you want to pick that up?
Yeah, absolutely. So we've got 2 security guards on site in Roniston out of hours. One of those is based permanently now within the emergency department. Staff have raised concerns about more. We can't put more in. There'll be one designated within the emergency department on a permanent basis.
But that second one could come.
Yes. The second one certainly.
24/7.
Yeah.
Thank you.
Just to add to that, we do know, and we're keeping an eye, and through the health and safety conversation, that staff feel that we're experiencing more assaults from patients. So we are working very closely with the police around how we manage that when we've got patients who are treating our staff inappropriately, and we're making sure that we're being very vigilant in terms of reporting that, supporting staff, and making sure we're working with South Wales Police to follow the appropriate path in respect of those actions.
And can I just ask, we do have the right data collection system to capture all that, do we?
Yes.
We do, yeah, is that good? That's super, thank you very much. Thank you. Any other questions or comments for Abby? Well, thank you very much, Dr. Rowland. So Abby, and thank you very much. We can take assurance from your report and the wide-ranging discussion. So we'll turn now to part 2 of our agenda, and this is all the really important part of the agenda for the board, because we absolutely, as a board, understand patient and staff experience. So first I want to Louise, very warm welcome again, Louise, and I'm going to hand over to Liz to introduce this item.
Thank you, Chair. This is a patient story, but it is more than that. I heard this story in my first few weeks here and thought it would be appropriate to bring it for us here. It is about our burns service, so a very specialist service and a regional service. So the story speaks for itself. A mother is going to tell us that story through film, but then Louise is going to talk about the service. But what struck me most was how this service has changed and adapted. So post-COVID, many changes, but is still able to provide the level of service that we do 365 days a year, 24/7 to those that need it. And in those difficult times, a very small team react with care and compassion. So I'm going to hand over to Louise.
Thank you very much for the opportunity to share our experience with you. I've worked for the Health Board for 35 years next month as a nurse, and I've spent most of my career in paediatrics and burns and plastic surgery. So I'm well averse to the changes within the health needs, and particularly around our burn service and the burns care standards that we're governed to and have to work to. So we were given the opportunity to innovate and change our service, which is something that a lot of people aren't fortunate to be involved with. So we were given an opportunity to look at what we needed, how we could make it work, and how to improve on what we had. So I'll leave one of our mums, Carla, explain to you her experience, and then I'll explain to you a little bit about the service, if that's okay.
We were in the house, me and Piper in the kitchen, and I poured a bowl of hot boiling water from the kettle. Piper threw her dummy on the floor, so I turned to pick the dummy up, and as I turned back, Piper had poured the bowl of water over to the top of herself, and she only had a vest top on. The water pooled in to the vest, which then I picked Piper up and ran straight upstairs, put her into the shower. We was in the shower for about 6-7 minutes. I was trying to call my parents as my partner Stefan was out walking the dog. My next door neighbour come running in because she could hear me shouting. Tried to phone an ambulance, but the ambulance said it'd take 7 to 9 hours to come. So as my parents come and Stefan's parents, they took Piper off me so I could get changed, and my mum was in the shower with Piper, but at this point her skin had already started peeling off her whole body and parts of her face. My next door neighbour took us to the Grange and they were amazing. They put us in the shower for an extra 13 minutes. Then she had a catheter fitted, tried to take some bloods from her and fit a cannula, but they couldn't take any bloods from her. Then we was there for, I think it was 3 hours. Then we got blue lighted down to Morriston, and we was in the ambulance for just under an hour, I believe. And at this point, I couldn't see Piper's face because she was facing outwards. And as I got the ambulance, it was so scary. Her face had swelled up completely. She looked completely different to what she was getting in the ambulance. But as we got into Morriston, then the team were waiting. 3 doctors and the nurse Tracy. It was terrifying because we didn't know what was happening. And then Piper was just laid on the bed with a catheter fitted into her and the bandages all over her. The team were amazing. Couldn't comfort us enough, but it was just scary. Stefan, Piper's dad, couldn't really control himself with his emotions. Piper was crying in and out of sleep and pain. 2 hours after we'd got there, we went up to HDU, and the team up in HDU were absolutely amazing. Tracy stayed with us, and Piper's breathing changed during the middle of the night, and then more doctors come in around her. But I think having that one-to-one care by the nurses was amazing, because you are also, even though you didn't know the doctors, you also knew the nurses, but it was a familiar face and a comforting face for somebody to speak to. You're seeing familiar faces constantly throughout the day, so you'd see the day staff and night staff, and it was nice because you know which one were coming in, and they would make like a bond with you as a family as well. The nurses explained absolutely everything, and the consultants themselves explained really, really well exactly what she was going down from, what she was having done every time, and how long it would be, and it would never run over. If anything, it'd run shorter. It was really good. They would let me go straight down to the anaesthetic room with Piper, and obviously leave as soon as she was under, but then they'd come and get us as soon as she was in recovery room, and we'd be there with her while she was waking up. She did come back the one time really agitated, but I think that was from the meds she was given. But other than that, everything else was brilliant, and she coped with the dressings on and with the medication as well, that everything she was having, they explained very well and what it was for. They also got us in touch with a different team to help counselling sort of thing. But yeah, but I felt comfortable talking to the nurses when they sort of staggered away then from not having that one-to-one care. That's when I got scared, because it was good to have the one-to-one care and familiar faces, but it was always familiar faces popping in throughout the time, and at the time before we were leaving. The nurses team would contact me once a week once we were home, and obviously we came every 2 weeks then, and then we've seen Liz once a month, I think it was, for 2 months, and then I went to 3 months. But yeah, but they'd always still contact us anyway, to phone just to check in, see if we were okay, and email as well, to see pictures of an update of Piper. Just by looking at her, like Piper now, like obviously her chest and her stomach, just looking at her just on a day-to-day, I just can't believe it, considering what she did look like when we first come in. The outcome have turned out a lot better. I didn't believe the staff and what the staff was saying at first, and well, still up until a year after I didn't believe it, but obviously it is true, because her skin looks amazing now. I think they were all kind and caring. Whatever we wanted or whatever we asked, there was always an explanation of why they were doing it and what for, and if we needed anything, they would always be there straight away. We just couldn't thank everybody enough, really. Everything we wanted and needed was there, and everything for Piper obviously was there straight away. We've been to the Christmas parties, and we went on the day out to St Fagans, which Piper loved. I just don't think they can do enough for all of their patients, their past and present patients.
A burn is one of the most devastating things that you can experience, and for a child to, as a child go through something like that is horrific and will stay with you forever. We were fortunate to be involved with change in our service previously. I worked on David Ward in Morriston, which was a paediatric burns and plastic surgery ward, and we helped the site out with taking over 16 to 17-year-olds from all other specialities. Pre-COVID, and then post-COVID, we had no service left because the ward had been utilised for something else during COVID. All the staff had been redeployed, and we were faced with losing unit status for burn care. So we were given this amazing opportunity to sit down and design a service that was going to meet the needs of the children of South Wales and our catchment area, but also to embrace change, embrace how the service and the health service works now. And as we all know, health service has moved forward with diversity, change of practice, looking at patients more on a community basis, length of stays. So we were able to design a service that was going to meet the needs of our children and meet the needs of the burn care standards. So I've just got a quick little presentation for you. So these are the burn care standards that we were faced with. So we had to find care for children over 6 months old with a 30% total burn surface area. So if you imagine your body is 100%, we had to look after children that had up to 30%. Babies under 6 months up to 15% total burn surface area. And then we had to look after complex things such as hands, feet, perineum, circumferential burns. We also had to be able to look after children up to HTU level, and also children that would require intubation and ventilation prior to transfer to the service. We also then had to include non-accidental burns and children with complex needs. And the things that we would never meet are neonatal on the same site and thoracic trauma, cardiac and major trauma. So we've got a local agreement in place with Bristol. We've just recently revised these SOPs because we've got a big network meeting review going through on the 11th of June. So everything's in place for that review. So this is a really busy slide, so I'm going to apologise for it now, but it just covers the standards that we had to meet, which are 2 paediatric trained nurses, 1 a registered burns care nurse, a paediatric nurse with available 24/7, an EMSB, which is emergency management of severe burn trained nurse, play specialists with burns experience, and EPALS trained, and we all had to be members of the burns MDT. So it was quite a challenge we were faced with to meet those. So what we came up with was 3 levels of care. So we have a level 1 plan, which is for children under 10% requiring admission or outpatient care. Level 2, which is 10 to 30% requiring 24-hour HDU care. For this, we have a 24/7 on-call service, whereby if a child comes in with a burns injury meeting this level of care, we would come in and switch from a daytime service to a 24/7 service and remain with that child in Oakwood HDU on a one-to-one basis until they were stepped back down to the ward. And then level 3 is critically ill, so we would come in again and stay with that child and arrange transfer via watch to our centre in Bristol. It's quite a challenge to achieve this, but we were faced with either upskilling nearly 80 paediatric nurses to meet that, or to go hybrid and have a group of specialist nurses that would provide this care 24/7 and would meet all the standards but be experts in that level of care. So this is the paediatric outreach team. We comprise of myself, which is the advanced clinical nurse specialist. There are 5 specialist nurses, 2 clinical specialists, and we have some admin support. We have all been trained to meet the level of standards required. So we are all trained burn specialist nurses, trained HDU specialist nurses, and able to perform care for a child requiring ventilation. We attend annual updates and days to maintain our training, because it's not something we do all the time, but we have to be trained and maintain that level of care. So we provide, as we said, a 24/7 service. We're also have upskilled ourselves, that we've taken over some roles from the medical staff, so we undertake all our own referrals. We see patients from admission right through until discharge. We have a dedicated department which is open 7 days a week for clinics, and we basically are there from the start of the patient's journey right through to the end. For those of you who know burn care is a very unpredictable workload. So we can go from having 3 or 4 patients to having 10 to having none. It is very waves and very unpredictable. So obviously we can't work to capacity keeping in a service like that with just us maintaining the burn care service. So we looked at what we could do for plastic surgery, because obviously burns and plastic surgery run together. So we've incorporated the plastic surgery service into ours. So we run a plastic surgery clinic. So we attend to all of the needs of trauma patients, electric trauma, and MTC. So the role of the team now is we manage children. We believe as a service that, in line with the UNICEF Rights of the Child and the Health Board Charter, the children should be cared for and classed as children up to the age of 18. So our service runs up to the age of 18. We see on average around about 5,000 episodes of care on children during that time. We provide an on-call service. We run clinics 7 days a week. We cover clinics in peripheral hospitals because obviously our catchment is the whole of South Wales. So it's a lot of travelling for some of our patients and they're not able to do that. So we go down to Carmarthen and further, and we go to as far as Gwent and UHW the other way. So we run clinics in those areas. We manage all our clinics as much as we can virtually to offer that to our patients. We run a pre-assessment clinics and we do all our pre-admission preparation. And then additional roles that I've taken on then is obviously leading the service. I'm the network lead for Burns Care for the UK. So I lead all the nurses in the UK and Ireland. We also run a baby year splinting service, which is only run in 3 other areas of the UK, which provides splinting to neonatal children to correct ear deformities so that when they don't need surgery when they're older. We have hypersphagia-led clinics, and I'm off to Zimbabwe tomorrow with as part of the Health Board initiative with Wales in Africa, where we're providing hypersphagia surgery on children with a condition in Zimbabwe. We run our congenital clinics, we run safeguarding lead. We do all nurse-led referrals and admissions, which has taken time away from the medical staff, freeing them up to undertake other roles. We run a chronic wound care clinic. We take referrals from all of our catchment area for any health wounds or anything, and then we take part in health promotion, which I'm currently up in the Eisteddfod at this moment in time, so I've nipped out from there. So we're running a Burns stand today on health promotion and education for the children then. And then finally, I just wanted to touch on our Burns Club. Our Burns Club is the support group that's been running for 21 years, and we've provided support to thousands of children throughout our area, where we build their self-esteem and move them from being a burn victim to a burn survivor. And we teach them skills on coping with the changes in their lifestyle, how to adapt and deal with their injuries and their trauma, and how to learn to live with their condition. We've also been part of a 3-centre national trial funded by Health Inspectorate England with Birmingham University, which have just completed now, looking at paediatric parent administered dressings at home, and we've developed documentation that's been being rolled out to the UK currently. We've just undertaken the first ever World Max Yourself trial on paediatric burns, which is being published shortly. So as you can see, we're a really, really busy service. We've been fortunate to be involved from the start of designing a service to meet the needs of our patients, to meet the needs of the Health Board, but also deliver something that is delivering the best standard of care we possibly could, meeting all the guidelines that are in place. So to have been on this journey, we have been fortunate as a nursing team to devise it from the ground floor, being involved in every stage of its planning and implementation. And I just hope that the story with Piper demonstrates that the service is working and we have embraced change, because I think that's something that every department and service needs to do, is look at what can be done differently. And we deliver really now a better service than we were delivering pre-COVID so it has worked out really well for us. So I hope that shares a little bit about our journey and our service for you.
Oh, well, Louise, it isn't just working, is it? It's world class. And I do hope that you and your colleagues are so very, very proud of what you do, because it's given me goosebumps just listening to it. It's just phenomenal. And well done to everyone. And just to think that you have built up a world class service.
We are really proud of it.
Oh, absolutely. And we are so fortunate that we are the board of an organisation that has you and your team in it. I'm going to open it up now. Nicola, I know that you want to come in.
Louise, thank you very much for sharing that story with us. It touched quite a nerve, I think, listening, especially to the mum and how anxious she was feeling. Continuity of having that one staff member, that was really key. I think it helped hugely. But I think for me, it's the transformation of the service is absolutely incredible. And then just wondering if it's something that we could be looking at with other services as well. But yeah, so to congratulate you and the team.
Thank you. I have our service model and design has been, I've been asked to, Leicester are looking to adopt it, and I've been asked to go to other services and talk about, because this is not something that we with the decrease and length of stay, but other burn services are experiencing it as well as a national sort of thing. We all know with, you know, with bed occupancy and that. So it's something that a model that has been looking to be adopted otherwise as well.
Jean, please come on.
Thank you, Jan. Louise, I've just written down a couple of things. And apart from saying that is absolutely phenomenal, the story, I think you and the team are phenomenal. But don't ask me ever to write a job description for you because I've got nurse, author, change agent, motivational speaker, humble, unassuming. I could write this and I could speak to you all morning because I find you so motivational. But one of the things that I would really like to ask is, when you say you're fortunate to design the service that you want to give, looking back, you not only changed the service within Morriston, but you have to reach out across the area and across South Wales, really, don't you? So what did you find most difficult to achieve, and how easy was it to take those other people within your service with you?
When I returned to the service, I returned on my own with a play specialist. So we designed our service with band 6 staff. So they've come with a lot of experience to the service. So to upskill them was really easy. And because the jobs were very desirable, the staff that we've got are very motivated, very keen and very enthusiastic to learn and develop. So that part was easy. We linked in with all our community teams throughout Wales, and they embraced a huge amount of teaching and embraced a lot because they want us to be, if we can provide a better service to our patients, we're allowing them to learn and embrace. So we've got really close links with all our paediatric community services within the health board and within each health board, and it does involve a lot of travelling, and it does involve a lot of commuting about and communicating. You know, I went on a home visit to Aberystwyth last week because I had to meet with a community nurse there. It was a very complex child that needed specialist care, and we work very closely, and they know they can link in with us and we will provide that service to them. So it's about building a network around us with all of our community paediatric teams to enable that service to support. By us supporting them, they're then supporting us, and at the end of the day we all want the best for our children and our families. So that's been really easy. And again, engagement within the clinics, the staff are really accommodating, really good, and want the best for their patients, really. I've got to say that through all the services we work in.
Any other comments, questions? Abby, do you want to say?
It's fantastic. A really good example. And I think one of the things that you described is that that really struck with me was the ability to kind of design your service from the bottom up and think about how could you make it work in the most effective way. So really grateful to you, Liz, for bringing it to our attention. And as you say, real exemplar. And good luck on the trip. So not only are you doing it in Wales, but taking it to Africa too. It's really,
we've got to Zimbabwe tomorrow.
Brilliant that we're able to share with countries that don't have the opportunity, and some of those children wouldn't have access to it. So again, that's a brilliant thing to hear, and good luck with it. And it'd be lovely to hear how that's gone and your experience. I don't know whether how we can feed that back, perhaps in a board briefing or something around perhaps a broader conversation. And Jan, we have talked about how we make sure the board is cited on all of the kind of specialist services that we provide and that we're providing for a bigger population. And this is one really great example of how we're developing that. And I think that close hand in glove working with the community teams where those children live, because they need to get back home and they need to go back into their own community, because presumably they're with us for quite some time, some of them.
Yes.
But that transition back home is clearly what every parent will want and need. So thank you very much.
Thank you, Louise. Dr. Brown, now next, I'm pleased to take back the board's warm appreciation and congratulations to all of you involved in this. You know, you've uplifted us this morning, really, and inspired us.
Thank you
And
very much.
we are about to bring back a formal board walk round programme, which will be starting in Q2, and we will make certain to include a visit to your service as part of that walk round. And we'll ask Richard to let us know when you're back from Africa, and then we can do a piece on that as well. Thank you.
Thank you very much for your time.
Thank you.
Thank you.
Thank We'll move on to part 3 of our agenda then, which is focus and the board looking ahead. And we will always have some kind of population health item on this agenda. I mentioned at the start that we are refining our committee triple alert advice assurance reports to the board. And Steve, the Vice Chair, who leads on design and development of this, is going to give us an explainer on what this particular situation involves.
Okay, so the board is aware that we introduced the AAA approach, I think last summer at some point, and the idea is that the key things that come out of the committee meeting, that the committee independent members and especially the chair wants to bring to the attention of the board is shown as an alert, and the alert is usually the committee chair usually explains the alert to the board during this meeting. There was a question and that was embedded, you know, during last year, and it seemed to be going pretty well. But there was a question in my mind, I think other people's mind, and the question is, well, so what? The board is alerted, but then what happens? And so we've refined the process a bit further. So if you look at the Population Health Committee AAA report there as a sort of template, what we've added in now under the alert section, first is a minute reference, and that's a reference to the committee minutes, so that if a reader is interested in going into more detail for the alert, they can refer to the minutes. There is then an executive lead, and that's important because the way we're doing this is the chair and the executive lead will agree on the alerts paper as soon as it is produced. And I have an undertaking from board services, at least from Hazel, on their behalf, that the alert paper will be ready within 48 hours of the meeting. So the executive lead, who should be in this meeting and normally will be able to respond to the alert and not have it as a surprise with it, you know, in front of them. There's also a reference to the associated risk in the risk register. If there is no risk, there is an explanation why there isn't. And as you see, as you go through the day, there isn't always a risk associated with these alerts. And then there's the alert itself. And so the way I think it will work is that the committee chair, as I'm about to do, will bring the alert to the attention of the board and allow the executive to respond. We will also then take it back to the committee so that the alerts become a kind of second action log, and how those alerts have been dealt with will be the subject of future discussions in those committees. There are a couple of little wrinkles here. For example, if the service group brings a report to, for example, population health, might be mental health and learning disability, as was in March, the service group director who brings the report is not an executive, and so will not be in this room to respond to the alert. So that falls to the executive who is responsible. In that case, it would be Deb, and she's not in those meetings. So there's a little bit of a wrinkle that we need to iron out. The idea is that when there's something that in a committee meeting which is significant enough that we think in the committee that the board should be aware, then it is made aware and something happens as a consequence of that. So that's my little tutorial. As the chair said, it is a work in progress, so happy to take suggestions as to how it might develop further. I've seen, both in Wales and beyond, I've seen a few versions of the AAA approach, and they're all a little bit different. So we can write our own story here. So happy to take advice from you as we go through it. If there are no questions on that, I'll go to Anne-Louise. Sorry, Chair. I'm taking your
You mentioned a wrinkle. The wrinkle I found is that if you try to look at the minute reference, because the next meeting of that committee hasn't happened and ratified the minutes, it isn't in the document, so you can't look at the minute. I could do it on QNS because I had or on mental health because I had the draft minutes because I'd looked at them and approved them for corporate services, but I couldn't find the reference because they weren't going to be there until the next time. And I just wonder whether we could put draft minutes onto the documents and until they're ratified, and then they can be approved minutes, so that you can, for members of the public perhaps who want to look at it, they would be able to find reference to the minutes. Otherwise, time will pass and they won't have them.
I'll defer to Hazel on whether draft minutes.
I think we can look at that offline, really, just the workings and probably, we can take that offline.
We run this model obviously today, and then committee chairs and lead execs can refer any additional points back to Steve and Hazel, and rely on the further information. So Steve, please take us through the Population Health Committee now.
Okay, so these are the committee wanted to alert the board to 3 matters, and the first one is, and the executive lead, in this case, the Director of Corporate Governance. This is not the ideal committee to kick off with because we were between executives at the time, and this was very much in a reset committee meeting. So it's not typical of the alert reports that you'll be seeing today. So the item there, the committee effectiveness report regarding Population Health Committee being in a transition phase. That's what we said. We did our self-assessment, and we assessed ourselves as not performing properly because we were in the middle of a reset. But that's reset is taking place now. Hazel, if you want to come back on that. Yeah.
We've held a workshop, which is really positive, really. We've looked at our work programme, the terms of reference, and with Jill obviously being new, fresh eyes approach on it, and that meeting in June now will be the first time that we reset that and take it forward with a revised work programme, and the terms of reference were approved at the last board as well.
Yeah. And the second alert, which we brought to this board's attention in the past, is the capacity of the population health team not being sufficient to fulfil its remit. Hazel, do you want to?
Yeah, and I know Jill, Fresh Eyes approach again coming is looking at that now and doing some benchmarking, so that work is underway as well.
So perhaps Tina could help Jill on that exercise of benchmarking, etc. Tina, would that be okay? Yes. Go ahead.
And the third one's a little bit niche. We consider ourselves, we are an anchor institution, and we have population health responsibilities, but also one of the aspects of being an anchor institution is we are a major employer. And it was noted by a committee member and supported by others that the food offering for our staff and also visitors at some of our sites is not of the highest health standards. And it's Morriston Hospital. I'm not going to advertise the brands, the franchises that are there, but they're not always the healthiest. And we would like that situation to be looked at as and when the contracts come up for renewal. We had the advantage, Marie was in the meeting, and she told us about the Cardiff and Vale adventure or journey, and they've got very much an own brand healthy option for staff and visitors there, which we don't have in all of our sites. We do in some. So that's something we think in the medium term should be looked at. And the lead exec is not here. It's Jill Richardson, so I'll take it up with her, but she's aware of this issue.
Rena, I know that you wanted to come in on this item.
Yeah, just a quick point really on the latter area that Steve referred to. What struck me is that we do have healthy options in our staff, what are regarded as the staff canteens, for want of a better word. But the reality being, a lot of the public don't know where they are and don't know that they're available to them. And I did wonder whether, Richard, we could do more in terms of actually publicising the fact that anybody can use the staff facilities, not that they're staff facility, anybody can use the catering facilities within Morriston and Singleton, where they do have a range of healthy options. I've actually been and sampled them myself. The reality being they don't have to go to the commercial vendors at the front. So in a way, I just feel there needs to be a little bit more understanding of that, of where they are, because I don't think the public know it and visitors don't know it.
Richard, do you want to come back on that point?
Yeah, I think it's a good point around wayfaring, particularly in Morriston. I think it's obviously in Singleton, there's less of an issue because it's more obvious there. Quite useful actually. I'll be with the volunteers next week as part of the Volunteers Week, so on the front desk there. So it'll be a good chance to get their sort of impressions of what people know in terms of what's where in Morriston, and also like in the strategic equity plan that I'm going to consider shortly. There is reference there as well to looking at wayfaring across our sites. So I think it is an issue that we need to look at.
Just so we'll give you an action for that point. So Darren, I know that you wanted to come in.
Yeah, thank you. So just for clarity, the lease of the commercial outlets with my team in capital plan because of the lease aspect to it. And the lead exec has already notified me of this query. So I've already asked for some feedback on parameters and the options to possibly make changes here, and I'll feedback to the committee as appropriate.
Great, so can you pick it up through the committee then?
Yep.
Any other points or questions for Steve? So thank you very much, Steve, and the board explainer as well. So we've received the evidence and taken assurance from the actions that we've identified, and nevertheless we will be hearing more as the committee reports back to us at future meetings. So we turn now to one of our new agenda items, as I mentioned earlier. This is now, if I'm not in this, because I thought it is the first time we've looked at the whole of this landscape. So, Marie, hand over to you.
Thank you very much, Chair. Yes, there is a lot in here, and I think this report obviously will evolve based on feedback that we receive from board members and other partners in our processes. But essentially, the approach that I'm trying to take with this report is to provide board with an overview of the work that's ongoing within the portfolio that I oversee and direct, to provide assurance and also to seek approval where required in order to move our plans forward. So as you'll see from the report, I've set it out essentially so that it covers our local health board strategic and annual or 3-year planning approach, and then I provide an overview of our partnership plans that we are taking forward in the statutory partnerships within which we are responsible, and also an overview then of the key commissioning activities that are taking place from a commissioning lens, and then sustainability and climate change, which currently also sits within my portfolio, and the emergency planning, resilience and response. So my suggestion is that we keep those headings as a standard set of headings, because it will enable us to keep a running overview of the activities that are going on within those areas. But as this report evolves, what I would like to do is to include more highlight reports and less text for you to go through, so that there is a more structured overview of what's happening, what's coming up, and what is required, if anything, specifically from board colleagues. So I will hope that you have all had the opportunity to read the paper, and I do want to leave an opportunity for colleagues, board members, to ask questions. So just a few quick points to kind of draw out, and then I will open the floor for questions. So in terms of the strategy refresh, the organisational strategy refresh, we did some work on that through a board briefing last month. I think the date's wrong in there, actually. It says May, but in fact it was April, end of April. So we will be bringing back the final version of the organisational strategy to June board development, and then we will hopefully get that signed off and out July. And that will give us the firm foundation then to do the realignment work with our existing strategic plans, of which we have a number, but also most importantly, or not most importantly, as importantly, our clinical services strategic plan. There's a lot that we need to formalise and agree that already pre-exists, that we already had a services strategic plan. A lot of that is still extant, but we now need to make sure that we work closely with our partners, and in particular with Hywel, who are also producing their strategic clinical services plan alongside us, and we will need to ensure that those planning assumptions and key milestones and deliverables are very clearly aligned. So that will come back in terms of scope, key outputs and timescales to our July board for board support. In terms of the annual plan, we will pick up. I mean, we are in the process now of, so we've reported the close down of 24-25 through Performance and Finance Committee, and we are rolling forward much of the actions that were incomplete. There were many that were completed, but there were some that were incomplete into the 25-26 plan. We know that that's already under significant pressure because of our financial position. And the proposed approach that we want to take forward in terms of both managing the delivery of the plan in year and making sure that we're clear and focused and purposeful in how we address the refresh of that plan for next year, is that we build that into a continuous review cycle, which is integrated. So we have got finance over here, workforce over here, quality and safety over here, and planning somewhere else. We are bringing it all together into an integrated approach that we will formally report on and manage on a quarterly basis. We've got a clear look back, understand what that means for us today and what that means for our plan going forward. So we will be bringing that as a proposed approach and formally reporting to board through this paper. And it will have to look very different because we have to address some fairly significant sustainability issues, both in terms of our financial sustainability, but also some of our service sustainability pressures. So that's it on the kind of highlights from the planning cycle. The Regional Partnership Board is a complex and busy space. There's a lot of work going on within the Regional Partnership Board, and we are the Regional Partnership Board along with our local authority and third sector colleagues. I will be providing for Audit Committee a partnerships tracker, which describes exactly who, what, where, when and how, so that we've got a really firm grip on governance, something that Nuria and I have now agreed and is in development. But in terms of the key pieces of work, there's just a quick overview in this paper and an attachment of the annual priorities that sit under the 7 key programmes that sit within the RPB for delivery this year. I think it's fair to say that those 7 programmes vary considerably in terms of their size, scope and complexity. It's hard to get a flavour from the attachments that are there at the moment about what is the material difference that some of those programmes are making. So what I will bring back to board in future is a highlight report for each of those programmes that's very specific and explicit about what is being done and how that is being monitored. I think it would be fair to say that a lot of the focus at the moment is in the Communities and Older People's programme, where there's some really good work going on, looking at our whole system approach to how we're managing some of our system pressures, both in terms of our urgent care pathways. So Deb and I work particularly closely with colleagues in the local authorities to look at how are we improving some of our flow both in and out of hospitals, and then how are we working together to develop a better approach to planning and commissioning longer term care in the community. That is a long haul. That's a big piece of work, but that's something that we've got really clear commitment to from our local authority colleagues. And also in the mental health and the children's services space, big pieces of work that are ongoing, but probably need some work to refocus and prioritise. So lots of positives within the RPB arena, but but lots of activity, and it's really important that that activity is translated into outcomes and results, which is what we're organising to deliver. I've given a very high level update on where we are currently with our Public Services Board colleagues. So within Swansea, there's an action plan for 25-26 that's now been signed off, and that provides the framework for a lot of our strategic planning as well as our partnership work. So there's some good work going on in the PSB space with both Swansea and Neath Talbot. Neath Talbot yet to sign off the action plan for this year. I think that's coming to the next PSB, but some good work being undertaken, evaluating the benefits of the actions that were in the 24-25 plan and the annual report that's currently in preparation to report back on that, which I can until it comes back to this board for information. Regional Joint Committee, and again, that's work in progress. A platform there to really build and launch from the integrated clinical services planning. So some really good work that's been done particularly in the eye care programme. So from a clinical services point of view, lots to build on. A bit more to go, I think, in our orthopaedics programme, and pathology obviously remains as a challenging position before we coming back to board in September. Again, we will propose that through this planning and partnerships report, we will be referred to, as Steve said, in the population health report, the regional health economy reporting will come through the population health committee, and we'll need to confirm that we are in research and development reporting. But I'm happy to bring the clinical services planning reporting back through this report.
Research and innovation will come through data digital committee. Excellent. Put after again.
Excellent. Good to know. And in terms of our partnership working with Cardiff, so that's the Regional Specialised Services Partnership. Again, some very niche pieces of clinical planning there. That the hepatobiliary programme, I think, has reached its end point in terms of where we can get to as an integrated partnership, and that's largely around affordability and funding from a JCC and from a commissioning health board perspective. So we've had to close that programme. The gynae-oncology programme is continuing to work in progress with a very operational interim focus at this point. And we've just had confirmation that the JCC is now initiating the review of cardiac surgery services. So we are currently in the process of engaging with the JCC alongside Cardiff and Vale to ensure that we are influencing the programme initiation process and documentation to make sure that that's going to take us where that service needs to go. So that will be potentially a big programme of work that will require significant participation from our clinical leaders. There's a number of reports then on where we are with our commissioning approach, which covers the Joint Commissioning Committee, the alliance model that we're developing with voluntary sector colleagues, an overview of the commissioning approach that we're taking and the priorities within the Regional Partnership Board, and the Area Planning Board, which of course is the body that oversees and coordinates the approach to substance use services and integrating across partners, and then an overview of our individual patient commissioning priorities as well, relating specifically to continuing healthcare. There's a very brief overview of where we've got to in terms of refreshing our climate action plan. There's good joint working across the organisation in terms of our adaptation plans, task and finish group that's been established, and I think the UHB's approach and progress has been very well regarded by Welsh Government. And again, there's an overview of the emergency planning and resilience work, and we will be bringing back I think quarterly a highlight report on where we are in terms of business continuity training, planning and delivery, and emergency planning and training, and also the annual report which we have to submit to Welsh Government and using the title, and we'll be bringing that to the next board report for formal sign off. It's a really quick canter through what I guess is quite an enormous.
I should take a breath now. Before I open it up, Nuria, do you want to add to the work of the audit committee on everything you're doing around the governance of different partnerships? And I think it would be helpful as well, as Marie's saying, developing the tracker. If we could have a sense of the status of different partnerships, which ones are statutory, which ones are inter-health board, that would be really helpful as you develop that work, Nuria. Would you like to give us an update?
Absolutely. So Marie and I have had a chat about what we need in terms of providing assurance to the board on the governance arrangements that are in place in relation to partnerships. And we've discussed the idea of having a tracker that would do exactly what you've described, Jan, that would actually tell us which ones are statutory, which are not statutory partnerships, where we're at in terms of reference, status of memorandum, etc. And more importantly, that we can kind of, as a board, understand where we're at in terms of the different partnerships and governance arrangements that we have in place, how those feed into our decision making and where the decisions go. So that's what we've discussed. I don't know whether, Marie, you want to provide more detail in what you're bringing to the audit committee, but that's where we're at. And I'm really looking forward to the paper, because I think this is a really interesting paper. This is the first time that I've seen the strategic landscape mapped the way you have it, Marie. I do have some questions, Jan.
Yes, but well, please start then, Nuria. We'll start with you then, Nuria.
So I actually have two assurance questions and probably one ask. I'm going to start off with the ask. So reading about the various partnerships, I was struck that there seems to be a gap in terms of a coherent overarching vision, set of outcomes and measures that will kind of bring things together in terms of the direction that we have collectively in terms of travel and our individual contributions as a health board. So I think that my ask is around, you know, in the next iteration, can we get a sense of that? And is that a fair assessment, Marie? I'm also very conscious as the third sector representative in the board that the description of the third sector at the moment in terms of partnership is very much on the commissioning. And I know that my colleagues will want assurances that we see the partnership with the third sector as transformational, not just transactional, and are baking that into our plans for reshaping care across the region. So if I could get assurances around that, that would be really helpful.
Yeah.
And alongside that, can I also get assurances that when we use the term co-production, we use it as per definition outlined in the West Glamorgan Action Plan, doing things with service users and communities as equals. We regularly use the term co-production when what we really mean is collaboration with partners on different bits of our own organisation. And there is lots of examples in the paper. So can I get assurances that we'll get this right and that when we use the word co-production, we actually do mean co-production?
Absolutely. Thank you very much, Nuria. Those have been really helpful observations, and I can certainly provide assurance that we will have a more intelligent assessment of where we use the word co-production and collaboration, because you're absolutely right. There is a lot of collaboration. There's actually not a great deal of co-production. And sometimes that's for good and appropriate reasons, and sometimes it's not. So I think that's a really relevant and appropriate challenge. So thank you for that. And in terms of third sector, you're right. Third sector colleagues are an essential part of our delivery mechanism in our partnerships, and certainly within all of our RPB programmes and work streams. They are well represented and an important part of our planning and delivery process. So again, absolutely acknowledge that. And to just come back to you on the vision for partnerships and our role within them. That's an interesting challenge, probably worth a bit more of a chat, because I think it depends which partnership. We have slightly different roles and inputs depending on which partnership we are in. But I think in terms of understanding what, as a health board, our contribution is in each of those partnerships, it's really important that we're explicit about what that is. So I would expect in the tracker area that I'm developing for audit committee, that is one of the domains that we need to make sure we're really clear about.
Would that work, Nuria, in terms of like the overarching approach to partnership working and when, why and how we engage as...
I I think at the moment, yeah, absolutely. I think at the moment it just stands out as a gap. And I think if we can get that into the tracker, that would be really helpful to give us that assurance.
Great.
Thank you. And are you happy with the other assurances that Marie's given? We'll look at the language of co-production, the language of collaboration to make sure we've got it right there as well.
Yeah.
So I've got Pat, then Darren, Andrew, Jean and Steve. Pat.
Thanks. Yeah, in terms of the governance, first off, in terms of kind of a third line of assurance, really, it would be quite good to understand whether partnerships have been reviewed independently and to have that included on
the tracker.
Yeah, on the tracker, because it's, you know, the quality of those does need review. In terms of the regional partnership board, it does appear that we're starting to see benefits of the health board increased engagement in the RPB. I think you can see that coming through in the focus of the RPB, you know, exceptional, you can see improvement. I think it was great to see that focus on urgent integrated care, you know, jointly provided from health and social services. And it's great to see that that group has been established, the special executive group, which you'd co-partner with Andrew Jarrett. I was just, what I was wondering is, it doesn't mention so much, but how engaged is Neath Talbot in that? Because I think that's critical. So just wondering on the level of engagement with that. I mean, it's a hugely challenging issue that's been around for decades, you know, moving to full budgets and everything, which is obviously the right direction to travel, but just wondering about their level of engagement in it.
Yeah, George, respond to that, Chair. I think there is a variation in the engagement, but there's also the same variation in the issues that we're facing. So I think Neath Talbot, we see far fewer delays, etc., particularly in the intermediate care world and then in the discharge planning through Neath. And we see far more through Swansea. So I think perhaps the increased engagement from Swansea is much more of a positive in terms of we can start tackling the issues there. That said, the part, I think it's a really important point that we need to make sure that we do have the absolute engagement from Neath, which is probably a little bit behind us. Marie and I probably need to work on that a bit more with Andrew and Angela in particular now. On the shop floor, I think Neath are fully engaged in that. So the work that we're doing operationally, particularly with the Morrison Service Group and the D2RA work, then Neath are really engaged in that space. So just make sure cover off that we've got equity between the two local authorities. But it is fair to say most of the issues we faced were with Swansea at that time. So we really welcome the increased engagement from Dave House and his team.
And just if I could ask as well, the centralisation of commissioning function. I know PFC asked to report on one's coming in June, but just ahead of that, you're mentioning now that that should be operational by Q2. I'm just wondering if it's an absolute critical move, isn't it, to improve the strengthening of commissioning?
Oh, yeah, so the internal centralisation will be in place by quarter. So we've got to make sure that we step through this and we don't end up shooting ourselves in the foot. So the first step is to centralise the commissioning process, you know, the fee setting, the protocols, all of that kind of stuff. The second piece that Deb and I have been talking about is actually how do we also achieve the standardisation and approach to case management so that we again have that as part of. Now we're working with the service groups at the moment to look at how would we bring that into a centralised process. That will actually give us a lot of learning, I think, and we want to try and do that over Q2 and into Q3, because we need to get into a conversation with local authorities about what would that need to look like in order to do that with our local authority colleagues. That's a bit of a legal minefield, a bit of a financial minefield, massive cultural challenge and a big leadership responsibility. So we need to understand what exactly are we asking, what will that give us, and what will it take to do it. So we're getting to that point so that by the end of Q3, we will know all of that and we'll have a plan for how we address it. So I think we absolutely need to go there. We absolutely need to make sure that we do it properly and at the end we do it once. And so our proposed approach is let's do it internally and let's look at what we need to do to get it done across our region. And if we pull that off, it'd be massive, huge achievement. Huge, but we need to make sure that we don't rush it and fall at the first hurdle, because we know that there are some significant pitfalls that we need to navigate.
Before I move on, can I just ask Marie, have we got the right resources then wrapped around this, given its importance?
So the honest answer to that at this point is I don't know, because I don't know what I don't know. So what we do have are lots of experts involved in helping us pull that together so that we understand what is the question we're asking, where are we trying to take us, where are the gaps in our knowledge, how do we fill them, and then how do we address it. So we have got a structured approach to it. I suspect we'll need to be looking to working with our colleagues in the RPB to come up with a single integrated proposal. And then we'll need to look at, have we got the expertise locally to do that ourselves? I suspect the answer to that is in large part, yes, but it might not be in totality. So we'll need potentially to look at how do we bridge that gap. But we need to do that at pace because this is running away with us.
Are we going to route that through the RPB?
Yes, we are. And we want it to be a whole piece of work. So it's not just about how do we pool budgets and collectively commission it, because part of the problem is the market isn't there. It's not just about how do we do commissioning together. It's actually how do we plan a service that we can commission and potentially jointly provide as well. So we need to look at the whole thing as a single piece. So we need to know what is our demand, what is our current capacity, what gap are we trying to bridge, and then how do we do that collectively through commissioning and pooling our budgets, but also having a joint approach to how we're trying to respond to the needs of our population. So that's the ambition, but we've got to do it quickly and we have to do it comprehensively.
So if we move that through the RPB,
Yeah.
Can we also ask the PFC to make sure we are tracking the spend that will be going into this and make sure that, obviously, as a consequence, we're going to get value added out of it, really. Darren, please come in.
Thanks, Janice. It's a very helpful thing going to what I was going to say, really, because when you look at this in its entirety, this largely describes how we're going to allocate our resource for the next 3 to 10 years.
Yep.
Whether it's locally within the health board or in partnership or in broader partnership.
That's the idea.
And getting that right is really, really important. I think it'll allocate our resources, it'll allocate the resources of partners. And our duty, therefore, is to make sure that the impact of that combined allocation is betterment and improvement. And my board hat is that's financial, that's value, it's quality. And the other thing that struck me in lots of the partnerships is they touch probably the most vulnerable in our communities. So it's also a really important aspect of this, that we channel the right resource to the right areas, get the value outcomes, but actually collectively with the pool of resources we've got, take us perhaps in other organisations to a more healthy financial footing in so doing.
Yeah.
So there's a bit of an offer there. It's an observation clearly, but an offer there that finance alongside that, we would like to get into this and the governance around that to make sure we deploy resources as effectively as we can across all areas.
And it plays into the strategic equity plan as well, the next agenda item. Thank you, Darren. Andrew, please come in.
Yeah, I was going to largely ask the commissioning question, but I've got a second question really about change control on the plan. And I think, first of all, thank you for the overview. It's really helpful to see all the different groups because it's not always logical, is it? These obviously have happened over time. So I think there's something from the audit committee about reflecting on a view on how that could be better shaped. Not that we've got to say, I understand that and all of that. But one of the things about partnership, obviously, is that people are trying to get something from our resources, as Darren said. And also, we're trying to get something from their resources, hopefully for mutual benefit. But that involves changing the plan. And clearly, that doesn't happen neatly at the end of every year in order for us to produce a new plan. So there was reference to the fact that if there is changes that have a financial impact, that would be there would be a governance within the health board to contain that, but also concerned about changes that are not necessarily financially impact, obviously, but represent a change in strategic direction or the vision of what we're trying to do and how those would be governed. So I suppose overall it's a kind of question around how do we manage the change control around all of these different inputs, which clearly are valuable and helpful, and we want to have those inputs, but then that has an impact on our strategic direction, our financial position, and how you see that being managed across those.
Do you mean specifically within the regional partnership? Or do you mean everything?
I mean everything really. I know that's a massive question, and I'm not expecting an answer, you know, in the detail, the granularity. But just thinking about our approach to the plan and the fact that we publish an IMTP, but clearly, I know it's not approved and we can't approve it, but we have a plan for the year.
Yeah.
What happens if we make a decision in one of those other arenas that has an impact on the plan, either to change the direction or?
So in some respects, bringing all of this into one place, into board, to test where have we got to, what does that mean, what are the implications? So if you consider them, so one of the things we want to do from, rather than have standalone performance reporting that just looks at where are we against all of the targets and, you know, so what are we doing about it? We need to look at that in the context of what we're doing, how we're doing financially, what we're trying to do in terms of delivering our performance, what that means from a quality and safety perspective, and what that means, do we need to change things in year, and what will that mean for ongoing years? So we're doing that internally to make sure that we've got that continuous review and that continuous realignment where it's required. And by bringing that into this place and also reporting, so I'm the kind of common denominator, if you like, across all of our partnership fora. So I will be the executive rep, I think, at all of our senior level partnership arenas. So where I see there being either changes of direction or interim issues that may need to be taken in, for example, Swansea Local Authority, that potentially will impact on our community services or our hospital services, we've got that instant in and that alert process to feed back in directly to board through this reporting. So from an immediate perspective, I think that's how we can continuously review and realign. From a strategic perspective, if you think about how we are directed by Welsh Government at organisation at statutory partner level, the strategies and policies that have been set by Welsh Government have been done so that we are encouraged to work collaboratively. We are encouraged to set consistent strategic objectives. We are all required to have due regard to the well-being of future generations, etc. So actually, when you look at a lot of the context and strategic drivers that apply to statutory organisations, they are very consistent. You would expect to see those consistently reflected, but it is something that we will continuously review and recheck as we reset our strategic plans, which we will do collaboratively. And as we review, so the wellbeing plans for the PSBs, for the area plans for the RPBs, for our strategic plan, we will continuously ensure that those strategic interdependencies are clearly articulated as part of that process.
No, Andrew, really good point in terms of all the different moving parts for this. But of course, it comes back to the 3 time horizons we were talking about in our board development, the here and now, the 3 to 5, and the longer term timeline. And this is a mechanism to try and hold all this together, as is the audit tracker, Maria, which is now assuming sort of war and peace dimension. But, sort of really helpful, just this is a way of holding it all together in these different time horizons. That's really excellent. Thank you. Jean, please come in.
Yeah, I think by the very nature of the conversation that we're having, it is complex to bring it all together. But I would endorse Andrew's perspective that it's the first time that I've been able to make sense of who the partners are, where they are. Yes, make more sense when we get statutory underpinning as well. And we cited on the commissioning element, because I don't think as a board we've had sight of that in the past. But I'll ask a granular question after I've just finished my diatribe, is one of the things that worries me is we have 100 pages that lay out all the granular detail, which is fantastic. But can I urge whoever is pulling this tracking together for, as Jan has said, short, medium, long term, however we describe it, one of the most important things for us, as well as things being kept on track, is the cost of everything that we're looking at and the funding streams. So can I urge whoever's pulling that together, Gareth, in the digital world, we keep it simple so that we don't have to trawl through that 100 pages to understand where's the funding come from, what have we spent, what have we got left? So that's my kind of, reporting question. But my granular question is that communities and older people, Andrea was managing. Who's taking that responsibility over?
Yeah, we're in the process of negotiating that. So we will need a clinical lead in that space. We know that so Kerry Todd will pick up some of that responsibility. But probably not all of it because the remit is too broad. So we're in, Deb and Richard and I are having a conversation about how we will bridge that gap because her contribution in that space was obviously significant. Yeah. We also have, just on that note, within the RPB, we've actually set up a special subgroup of the Communities and Older Persons programme, which is co-chaired by Dave Howes, who's the Director of Social Services for Swansea Local Authority, and Craig, to look at some very specific and quick pieces of service redesign work that we need to bed in quickly in order to address some of the priorities that sit under that broader programme. But notwithstanding that, we recognise that there's clinical leadership in there that we're going to need to identify and harness. Yeah, I think we also need to think creatively about how the plan cluster planning group can feed into that space in a more integrated way. So there may be some opportunities there, I think, to look at how do we. There could be an opportunity to kill a couple of birds with one stone potentially, but that's still working.
Chair, could I come in on just briefly on one point? So we are looking at the clinical leadership in that space. I think it's my view that we probably need more than one individual linked in, because while Dr. Mehta is really engaged in all of that, sometimes the dissemination of the actions in that struggle because it's all down to one individual. So I think it's how do we work across our system to make sure we've got clinical engagement at every opportunities to make sure they can share the work. Sometimes we just have one, it makes life a bit more difficult for that individual and then it doesn't quite get through the organisation as we need. So we'll be looking at that as well.
We'll take two more contributions now, then we will need to bring this to a close, sadly. But I know that Marie will take contributions to the refinement of the paper outside the meeting. So we've got Steve and...
Yeah, and I'll thank you very much. Marie picked up my point because it was about Plan Plus the planning group and how we're going to bring that into here.
Thank you. And we are issuing an invitation to Iestyn Davis to join us at the board from July onwards. There will be somebody around the board table from primary care as well. Thank you. So Rena, final comments to you.
Okay. Just quick ones really. Obviously, we've just been talking about population health, but it strikes me, having read through all this partnership, that in a way that is a clear thing that needs to, if you like, be embedded in our partnership working and needs to underpin what we're doing. And what I was quite surprised on a detailed level is that we mentioned within Swansea PSB that there's been a coordinated effort to tackle access to food as a whole system, but yet it's not in a key area of focus for 25-26. So I just wondered why it wasn't and whether we'd raised that. And the second point I had related to the sort of climate adaptation, because I'm really pleased to see that coming to the board because it's an area, again, I'm particularly interested in. But referring to what the chair was saying about this is really important in terms of future-proofing our services when we're going into the longer term beyond the 5 years. And we've really got to ensure that we do embed some of that work now to look to future-proof us. Otherwise, we could find ourselves in really serious water. So I just wondered if you could give any assurance on those 2 points.
So on the Swansea Bay PSB food thing, I can't, but I can take that back and find out. On the climate adaptation planning, you're absolutely right. We are seen as a kind of a lead, I think, in NHS work, some of the work that we've been doing globally. And that's taken investment, it's taken time, it's taken allocation of resource to do that. Trying to protect that because we know it's the right thing to do. Similarly with focusing on, early intervention, addressing some of our population health needs at the very highest level, at the very first opportunity.
those are always the things that are hardest to protect. We have protected these and we will protect these and I will make sure that I bring that reporting where we've got to and where we could get to. If we were able to allocate the resource that potentially is necessary. One of the big challenges, I think, with a lot of the adaptation is it costs more in the short term. It saves us in the longer term, but the initial investment is often eligible. And that's something that we're grappling with lots of things that we're trying to do. We can see that there's a better, more value for money approach that we could take, but the issue is that takes pump priming, so that applies to lots of things now. But I am happy to make sure that it continues to be formally reported back.
Thank you. And thank you again, Marie, for taking us through this. It's taken a lot of work to pull this together. So thanks to you and the team for that. So I'm going to just adjust the recommendations really as we go through this. So I think firstly, we support the approach that Marie has actually set out to our planning and partnership landscape and agenda. So that's the overall approach, and we will set it in 3 time horizons: the 25-26, the IMTP 85, and then the longer term plan. So within that, then we are supporting the direction for the organisational strategy refresh, and we're going to take that at the July board. Okay, so that's one clear item. We're also supporting, I hope, this concept of a continuous review cycle now of in-year and 3-year plans, so that we are constantly reviewing, mapping against the landscape. So picking up your point, Andrew, if there's anything that looks as if we need to change direction, we can pick that up. So that's a process that you will be bringing in, Marie. And clearly, as we're developing the approach to the clinical services plan, that is a methodology that will clearly underpin that.
Yeah.
So a lot of work for audit then, Nuria, in respect of the tracker around the partnership agenda and arena. So we're looking to audit as part of this tracking mechanism. Let's be clear what the status of each partnership is, its statutory underpinning, what we actually devolve to the partnership in terms of any decision making, what has to come back to the full board to us. Can we also put in as well the last time there was any review of the partnership structure, status, delegations, so that we're very, very clear? And would it be possible to put it together in a kind of governance map? So, and that you can map it back to what would have to come to the board when for what around the partnership arena. And then clearly another big piece of work around our commissioning agenda. Again, parts of that are operating through the RPB, but we are looking to our own performance and finance committee to really look at all the resources tied up. And as Darren has said, really start thinking about how does this impact on resource allocation? And it will help with a more sophisticated approach to resource allocation as we go through. There is a specific piece of work for this board to understand better, I think, all the services under the auspices of the JCC. We did earlier in the year, Abby, we were looking to ask Ian Green and Hugh George to come. We haven't managed because of various diary commitments to achieve that yet. But again, we'll use this as the vehicle. Could we ask them to come and then really set out with them the big issues for us? Because of course there will be fragile services in this as well, won't there? And also services that link across to the regional joint committee also. Yeah. Yeah. And then I think so, and also you've also highlighted there will be regular updates to this committee coming through as and when around emergency preparedness, resilience, response, etc. So what you could do in the refinement of the paper then is just plot what would need to come when during the course of the year.
Yep.
Okay. Yeah. So is there anything you want the board's agreement to raise specifically that we haven't covered?
I think you've covered it all, Chair.
Okay.
Yeah.
Okay, we're happy, we're content. Thank you very much, and Marie, thank you again. It's really pleasing to see this coming forward because it's such a phenomenal piece of work. Thank you very much. Well, so we've already mentioned in part our strategic equity plan. Sorry, Richard. Councillor there. So would you like to sort of take us through the strategic equity plan?
Thanks, Chair. So yes, so the strategic equity or equality plan is called We All Belong. That's as a result of everything we've been picking up in our always on engagement over the last 2 to 3 years. But there's a very clear context that everybody wants to feel that their needs are being catered up for, but also a recognition that there are inequalities in society. And obviously we've heard already this morning around population health. And one of the stark bits of context really for the strategic equity plan is around the differences in terms of life expectancies across the patch. So that's one example of how inequalities come into play. So the initial draft strategic plan was considered by the exec in March. It was informed by, as I said, our always on engagement approach. So it's very much service user led and staff led. So very much a bottom up approach to things rather than a top down approach from a sort of corporate perspective. We engaged on that then for a 6-week period. The nature of the engagement is outlined in the papers. We sought to check our approach to make sure that it made sense and whether we'd identified the right priorities for the first year. A number of key issues came out of that engagement and they're outlined on page 2 of the covering paper, but some of them included that everybody wanted it to be a plan for them. It was everybody's business, as it were. The importance of tackling the health inequalities I've already mentioned, a focus on equity as well as equality, embedding a compassionate culture, and also providing information in different formats and languages. So as a part, again, of being inclusive in terms of the way that we communicate with our population. So we updated the plan and we identified 3 priority areas. So those were embedding equity in all we do corporately. So that was the first one. The second was addressing those things that provide benefits across multiple groups, recognising that many people will be in more than one group in terms of protected characteristics. And then the third area of priority being around specific actions on protected characteristics. I suppose there's a question around whether there's too much in the plan. I think it has been slimmed down as a result of more focus brought to it over the last couple of months. There is a focus on 1-year actions, and I'd say that a lot of the things within the strategic equity plan are things that we're required to do in any case and are picked up in other plans like the population health strategy, for instance. There's some tough issues in there. I think primary care being one in terms of access, and that's something we're aware of, but something that we do need to tackle. And the other thing that will affect all aspects of our decision making as a health board is around the impact assessments that we need to compile. And I think the less difficult bit is actually coming up with the templates in terms of impact assessments. The more challenging bit is to make sure that it's embedded across the organisation and that they actually do inform our decision making. The benefits of the plan are raising the profile of inequalities and the importance of tackling them and providing us with a clear roadmap. There are some clear next steps now. There's a workshop that's taking place next month in June, and that will focus with the strategic equality, diversity and belonging group looking at accountabilities and also some metrics as well. There's also a need for us in the summer to pause and look at the Supreme Court ruling and the EHRC guidance that will be issued. So we'll need to review things in the light of that. And there's also a need for us to sync up effectively with the annual planning process. So there'll be an opportunity for that in the autumn as well. And I think I'll leave the introductory comments at that. Thanks, Chair.
Thanks, Richard. I'll open it up for questions then. Nuri, would you like to start? Are you on mute, Nuri?
Sorry, apologies about that. I couldn't unmute myself. I would like to start. Richard, thank you. I know that your team is hugely committed to the equality agenda, and I do thank you for the work that you've done to date. But I feel that I can't, at this moment, endorse the plan as it stands. Whilst I absolutely agree with the focus on equity on a personal level, what we're proposing here is to move away from the language set down on statute and used by the rest of the public sector, which is very much about providing universal access services for everybody. And I'm very happy for us to be bold in this way, but we need to make a more compelling case as to why equality alone isn't enough and what we will be doing to indeed lift our services and go even further. The Equalities Duty is is a legal duty. We have a legal duty to produce a strategic equality plan. And it is not simply an enabling document for our corporate objectives. There are specific things it needs to do that are set up in statute and have EHRC guidance attached to them. This includes setting up specific outcome-focused equality objectives over 4 years and the steps that we will take to meet them. There are other specific areas that we need to cover by statute, which you have covered, including the equality impacts process and approach that we will take. So for me, this is a really important document. And I do find the definition that we use slightly problematic because we talk about protected characteristics as people vulnerabilities. Now, I know people who are neurodiverse, trans, or from an ethnic minority background like myself are hugely proud. And as an ethnic minority, I can tell you that I don't see my ethnicity as a vulnerability, but as a strength. And the whole equality agenda has moved away from seeing vulnerabilities to seeing them as assets. So I think that I am in a position where I think we need to rethink some of the way that we're presenting this.
Thank you, Nuria. We'll come back to all the comments at the end, Nuria. We won't take yours specifically now. We'll hear what others need to come in and comment on. I'll open it up, please. Rina.
Yeah, I mean, in a sense, I do support the use of the word equity as opposed to equality, because I do feel it is where we want to be. And given what we know about our population, which Richard referred to, you know, that part of our population is actually, in a sense, much more unhealthy and has things like long-term limiting illness, etc., than other areas within it. So in a sense, it is about equity. But the problem we have is, as you just referred to, you know, the statute is the Equality Act. So I'm a little bit concerned, and perhaps we need more advice on this, is that are we going the wrong way in terms of actually using equity as the title, albeit that we've had a lot of responses from the consultations that we did that suggest that is the word that people would endorse.
Wait, let me see.
Yes, it was just to, so I think there's a lot of really good work in here, and why wouldn't we want to do a lot of this stuff? I was just commenting, Richard and I have had a conversation about how we ensure that this approach is embedded in the way that we are updating our planning process, both from an annual /IMTP planning process, and also looking longer term what we're trying to deliver from a strategic perspective. So ensuring that this is an embedded part of how we approach improving our services and the way that we support our population, I think is really important. And I suppose my only other point was around the impact assessment. And one of the things that we discussed as an exec team is the fact that we now have quite a wide range of impact assessments that we're expected to do with various lenses. And one of the things that we've discussed as a group is let's have an integrated impact assessment that addresses quality, that looks at health impact assessment, that looks at equality, equity issues. So we are doing it once for any services or service chain. So it was just to offer that for additional clarity.
So Tina and Louise and then Pam. Tina.
To me, it's a really good framework, a starting position, but I think it covers health inequalities of the population, patient experience and staff experiences, trying to meet a wide range of needs. And I just wondered whether the next phase might be to look at those strands specifically, drawing out what we want in those areas.
Louise.
Two things really. One is the semantics and the difference between equality and equity. And whilst I recognise that equality is the title in the Act, I can't see a problem with using the word equity when what we are trying to achieve is perhaps putting additional resources into reaching those hard to reach people. And maybe it's vocabulary, maybe we need to look at that. But I think the intention is absolutely right. I mean, I too, I think it's a really good detailed report, and it does provide achievable ends. What I would like to ask is, what would good look like, and is there, can we benchmark either within health or within other service to see where equity has been achieved and how it was achieved.
Thank you. Matt, to come in.
Yes, sorry, I just.
Good morning.
Thank you. I just wanted to say that this has been to the stakeholder reference group, but we ran out of time, so we put it as a main item for the July meeting, so we will be looking at it there. I think we use equity at work, but to me, equity now means what equality meant when I started doing EDI work, however many decades ago that was. It's just that the language has changed.
So is this actually time dependent? Does this have to be subject to approval today?
I think there's possibly a route through in terms of lots of Neuria's comments. I think I recognise where Neuria's coming from in those, and I think there's perhaps an opportunity to pick up a conversation with Neuria separately around equality and equity, and actually sharpening up the plan in terms of being clear around where we're meeting those statutory responsibilities and being clear about where we could need to go further. There's also a couple of other things in there that I think I'm happy to change. I think the definition, I think Neuria is right on that front. So on reflection, I think we can change that. And then some of the other things that have been raised around measurement and benchmarking, for instance, that's being picked up in the June workshop, where the measures and the ways of monitoring progress will be addressed in the June workshop. So that's work that's already in train in any case. I think those are the main things that have been raised, to be honest.
So it's not time dependent then today, Richard, really. It doesn't have to be approved today. And we do have a special purpose board in a month's time. So Abby, shall I hand over to you?
I think the comments have been really helpful, and this is a refresh, Rich, because we previously had a report, it's my understanding, because we've had a strategic equality plan in existence previously. So just if we've got the opportunity, Jan, that we can reflect those comments back around being absolutely clear what the legislation requires us, how we've gone beyond that in some respects, and providing a clearer narrative around that up front in the document. I guess the only time-bound issue, Jan, is in relation to the details that are around this year's actions, because we are already at the end of month 2. My sense is that there's nothing in the actions that you wouldn't want us to be progressing. So I think if we could have endorsement to crack on with the specifics that are in the action plan, whilst we sharpen and reflect the framing of the 3-year plan. And as Richard said, depending on when that workshop is, sorry, Richard, I did not when you said it, we could potentially include those things about, well, how would we know over 3 years that we were shifting the dials? What are the dials for a strategic plan? It's not all the granular metrics that we're following, but what are the big things that we would want to clock? And I think Tina's point is important, because some of that will be picked up in other arenas, like our workforce indicators, how we're responding to the survey. Others will be about how we ensure access to particular patient groups, and how we go further in terms of ensuring that we think about how do we enable people to access our services. I don't like the term hard to reach groups, because that implies they've got to come to us. There's something very much about how do we enable access for communities who need a different way of accessing our services, as we've talked about before. So if we do that, Jan, I think that will be fine.
Thank you. So we're content with that. So we can endorse the actions planned for 25-26. And in working these through, perhaps we could have some more detailed work on outcomes and impact expected. We'll bring the plan back to the special purpose board in June, where the additional work, as we've described, can be done. And Nuria, can I ask you to engage in this with Richard, please, and Tina, just to make sure that we have all the different views reflected. Nuria, are you happy with that?
Yes, happy with that, Jan.
Well, thank you, and thank you very much, Richard. I think there's not too much to do now to actually pull it together and to enhance it in relation to the comments that have been made this morning. So we've got sort of a refined document, given its centrality and importance as you've been describing to the whole approach to planning. Thank you very much. So Richard, we'll turn to you then for the final item in this sort of future focused election, looking at our voting strategy. for research, development and innovation.
Thank you, Chair. So the purpose of the report is to set out for the board the research, development and innovation strategy 25-26 and to seek the board's endorsement of that. Chair, as you said in your introduction, research and development plays a particularly important role in healthcare, not least because we know that outcomes for patients are better in institutions who are research active, with access given to patients for all types of research, from randomised controlled clinical trials to new drugs being available, to the use of data and the use of new technologies. And added to that, I think it's the role of R&D, research development and innovation in adding variety and to attracting expertise of our staff within the Health Board as a reason for recruitment and retention. And most board members will have been involved in the conversation recently that we had at the Regional Joint Committee, where we set out the rationale for developing a regional RD&I plan between the two health boards of Swansea Bay UHB and Howell Dda UHB. We recognise the importance of that, but also in the meantime the need for an individual RD&I strategy for Swansea Bay UHB, and so determined that the best way to bridge that gap is to develop a strategy that is 1 year only and to frame that as a bridging strategy. The papers presented there for board members. Just very, very briefly, it's been divided into 3 pillars, as you can see, in terms of RD&I culture, RD&I support, external, and the third pillar being external relationships and collaborations. We shared a copy of this draft strategy with Welsh Government colleagues in Health and Care Research Wales in advance of the Health Board's annual Research and Development Review in March, and welcome that opportunity to share that and to frame that along with Welsh Government colleagues prior to that review. And I'm pleased to say that the feedback from that was very positive, with a feeling that actually the strategy was sufficiently comprehensive to be a full strategy rather than just a bridging one. So it serves its purpose as far as Health and Care Research Wales are concerned. Following that meeting, the draft strategy was shared with Digital Data Research and Innovation Committee and with Management Board for endorsement. The former requested minor changes which have been included in the shared today. The DDRI committee, said that right, will be the route through which we receive regular progress reports on the bridging strategy. And just to add finally to say that all the objectives that are described as being planned for the year are within current resource control and or are funded by commercial income. And in fact, overall, we're intending that the financial implication is positive in that there will be more income than there will be spending on that. I'll leave it there.
Thank you, Richard. Thank you. Thank you for that helpful synopsis. Are there any specific questions for Jean? And then Keith.
Forgive me if this is my background, but research and innovation to me, this is heavily weighted to the clinical trials and the clinical environment, which I absolutely understand. But I would have wanted to see greater ambition in terms of research and innovation that links to things like productivity, efficiency, etc. And I don't see that coming through. For instance, if you look at the procurement, for me, it doesn't provide an incentivization to research or innovate in the procurement arena. It merely states what we're doing. So it's not that it doesn't lack ambition, but I think we've a piece missing that we have to build on, maybe with the help of the Digital Data Innovation and Research Committee. But it is missing a bit for me. Ambition is, I'd like to see a bit more of that, if you like.
We'll take Keith and Maria's points first and then come back to you. Keith.
Yeah, no, welcome the strategy. Great to see it. Swansea University is the U in Swansea Bay University Health Board. And from that point of view, I'd just like to endorse the strategy and say that it's very welcome and good to see.
Thank you. Thank you, Keith. Maria, please come in.
Of similar vein, I absolutely really welcome the strategy, Richard, and I really like it. And I think for me, though, there's 2 assurance questions. To pick on Jean's comment, one is about that tension between giving clinicians time to work on the R&D and their job plans with the need to maximise clinical time, given the huge capacity and demands constraints that we're under. So those assurances are really important. And then also, in terms of the audit committee, we picked up the significant reduction in spend on R&D in 24-25. So the question is the extent to which the ambitions in the plan are affordable and whether we're in a position to really prioritise them.
Thank you, Louise. So we've got those three elements there, Richard, then an expansion really, another part of the strategy around research, innovation, development, around the whole productivity, efficiency agenda. And then we've got the time for all different professionals, clinicians to engage in the work, and then the affordability, which you touched on earlier.
I think that is a fair point. I suppose it might be one of the disadvantages of having a one-year bridging strategy, being able to describe the breadth of that in one place. And on some of those issues, I would see that the relationship with Hywel Dda having the regional angle on this as perhaps being key, and the benefits that come from having either a much bigger population to draw on, a bigger group of staff to draw on, and obviously then bigger opportunities in some of those areas. Much of the activity that we've done in R&D is very clinical, and it has traditionally been very clinical by its very nature. But as part of this, we are looking to how we incorporate other, so it's not just medics, it's how we incorporate other professional groups, perhaps then consider how we broaden that out to other areas where we haven't looked at R&D in the past, like procurement, for example. So happy to take those on board as we develop the next bit. Is that right? And Mira, on your point, for clinicians, it's a very good question, and perhaps exemplifies the tension that sometimes exists when we talk about what activities clinicians undertake other than clinical care. So our job planning guidance provides for this very clearly and makes a distinction between how we set out what's called SPA, supporting professional activity within an agreed job plan for clinicians every year. And for clinicians who undertake meaningful clinical research, we can allocate up to half a session a week, a session being roughly 4 hours, so a couple of hours a week. But that can go up to being much higher, 1 session a week or even more, for those who are principal investigators or chief investigators on projects. So clinicians who, what used to be called or still called on portfolio or pathway to portfolio projects will get a far greater proportion of SPA time accommodated in their job plan in acknowledgement of the value that that activity has. And the reason that we allocate it like that in pathway to portfolio projects is trying to reconcile that for every session that we have agree that clinicians will be doing R&D, it won't be direct clinical care. And also balancing out the level of expertise amongst our clinicians in the health board, and that balance of people who are expert at their clinical job versus people who are both expert at their clinical job and expert in research and development. So there is provision for that through the job planning process. And on the, Darren may want to come in about this reduction in spend on R&D. There hasn't actually been a reduction in spend, but rather a technical change in the way in which the spend is allocated in the central accounting process. But I'm well outside my field. Yes, I'll let Darren come in on that.
Darren, George, to come in and add in.
Yeah, thank you, Nina. So in last year's audit process, it was identified that we've been netting off income and expenditure in some parts of the accounts, and we've not necessarily accurately reflecting the coding of some of that. But what I can assure board members as of today is that the figures that we saw through the analytical review presentation to audit committee, the expenditure is exclusively R&D expenditure. So the 5.455 million reported there is collected from the work that we do. The income is considerably higher at 9.5 million because the income includes not just R&D, the SIFT income and other teaching and research income. So that whilst the classification meets the accounts requirements, it doesn't give you a true picture of true R&D. What I can further assure with the board on is that I meet regularly with Steve Bain, that's the lead, and Mark Simpson, who's the finance lead currently, to make sure that there is no subsidy from health into R&D. As Richard described, that the ultimate aim here is for benefits realisation. Because R&D is specifically accounted for in its own way, we are allowed to move income differently across years. You would be, other than that, all the other accounting treatments are same as it would be for health board expenditure. So it's a long explanation, but right.
Thank you. Laura, you content with that explanation?
I think so. I'm trying to still come across with the explanation in my head, but I think so, Darren. Thank you for that. I might come back to you later to ask you questions.
So I've got Chris, Liz, and then I'll ask Abby to round up. Chris.
Yeah, thank you very much to support the strategy. Clinical research is a multidisciplinary input, and I think Richard put that. There's a healthcare science strategy nationally, there are AHP and nursing strategies coming up, and these all dovetail into this. But I think in the continuum where clinical trials are, to translational research into practice and innovation, there's a lot to do in that space, because that's where we will get our efficiency and our moving forward. So I think through this strategy and the regional work, I think added effort into that area, translating what is in research into clinical practice, rather than the end around clinical trials and that which is around individuals is important for us. And I think also as we take it forward, how we evaluate that research, and in terms of our innovation, are able to measure outcomes, pros and cons for patients as well in the larger, broader scopes. I think there's a lot for us to do in this space.
Yes.
I think I'm going to align an awful lot with that, Chris, and I really welcome seeing this here. But it is only part and only the start, I think, of what we want to do around research, development and innovation, because it comes at all levels in the organisation and is led by many different individuals and professions. The bit for me, though, is we know that outcomes are better for patients, staff experience is better, and we retain and we recruit really, really good caliber staff when we're research active. And so it does need to be more than the clinical trials piece. And the bit, and I'm asking myself a question as well here, but talking about the university and university health board, I think what I would like to explore is the clinical academic careers and opportunities that are available for all professions in partnership with universities and other, providers of education and research. We have got, I believe, some nurse consultants and some AHP consultants. We should be encouraging those roles to be research active. And for that, we need to have clear opportunities and framework in partnership with universities. So I will take that away and explore, because I don't know the answer. There may be many, but that's not usual, and I'd like to promote that.
Well, and that would be really interesting for all of us to find out more about that. Thank you. Abby, would you like to?
Yeah, thank you. And I agree with all the comments that have been made. And my suggestion is that in terms of the strategy we've got in front of us, that we do endorse it, because there is good work in here, but I think there is a lot more we can do. And I just wanted to come back to Jean's point. Completely agree with you in terms of those wider opportunities, because we know the universities have got engineering, they've got expertise in AI, in digital, and just to confirm that we have got an exec to exec with Swansea University coming up, where we can look to explore all those other opportunities and look at the curriculum and match through where we can do more together. And yesterday, I know it's a little bit late, but I had my introductory meeting with the Vice Chancellor and one of the Pro-Vice Chancellors of Trinity St David's, which has clearly got a much bigger presence in Swansea now with the opening of their innovation centre in the marina. And again, they were talking about their research being more applied in terms of nature. So it's not necessarily things like trials in patients, but much more applied. But there were a whole range of opportunities around, they've got project management, business schools, applied business schools, programme around healthy living and sport. And I know that Halvar have been doing work with them on their social model of health. So the combination of us working together and accelerating, bringing this agenda together across the two health boards, I think gives us opportunities to explore all of those things that we've got. And I was even thinking about how do we use their hospitality and catering and events management. If we're trying to do things, why don't we get the students to do it? And I think there's some real opportunities, and they're very keen to meet with some of us early on. Richard, as part of that conversation, and Tina with you particularly around alternative roles, how we're developing those alternative roles. And certainly the opportunity that AI, which is coming fast, will present and the work there. So I think this is a growing and expanding agenda and really exciting.
Thank you. So can we endorse the strategy as we have it in? And can we also ask for, of course, a widening of the domains of the strategy, whether that's for the bridging strategy this year, whether it's when we take it into the regional joint committee arena with Hanover, pick up all these additional domains. That would be really great. Thank you very much. So at that point, we've only got half an hour in hand. But let's have a 15-minute break. And I promise we'll try and have 15-minute break.
Well,
Silence phone.
Yeah, thank you. There were 3 alerts at the committee which reflected the pressures of sort of workforce, vacancy factors and entertainments. Another one regarding the training requirements and strategy was essential, which we've referred as well to the Workforce and OD committee. So we'll be working jointly on that. And the third one was really the importance of a joined up business intelligence strategy and clarity of next steps. And so those were the 3 alerts, just to say those. And then there were 2 other things that were of particular note, which was the limited assurance of the clinical coding, internal audit and the records management. All of those items we are picking up in our ongoing agenda to make sure that we're monitoring them, making sure there's progress against all of those items. But maybe I'll ask Gareth if he wants to respond.
Thanks, Andrew. In terms of the alerts, I think the alert that was raised in the March meeting was around particular vacancies. So just to give you assurance, those vacancies have gone through our vacancy control process and been approved. So they're in the process of being filled. Like most things, we've got a longer term, an immediate plan and a medium-term plan and a long-term plan. So we've, as a result of our performance and finance review, we've got a list of priority vacancies outside of those 3 that we're looking at, and we've agreed with Darren to look forward to a forecast to what our outturn position will be for the end of the year to make sure that we can meet our financial requirements as per the financial plan, and then understand what that means in terms of the scope of vacancy filling, and then what we may have beyond that to non-recurrently fund key things that we would need to do in the mobilisation of the digital strategy that was approved previously in March. So hopefully that gives you some assurance around that. In terms of the workforce and recognising the training, that's a fundamental pillar in our digital strategy, but also within the workforce strategy. So I know that Matt and Tina are working together to look at how we approach that and bring that together. And I think that might be the work you'll do with what the committee as well. And then in terms of the BI strategic plan, so the BI draft plan, BI plan, strategic plan has gone to the BI meeting the group and been approved. And the intention then is now to take that through management board and then up to DDRI, hopefully in July. On the clinical audit, I think we recognise that there is further assurance that is needed. We've got a plan in place to try and address that with the use of AI to support that and changing roles to make sure we keep the staff we've got in place. And that plan is in action, and we'll report that through the DDRI committee in terms of progress towards that. And then in terms of the records management audit, obviously that audit was broader than the acute record.
So we've already amended some of our key policies to make sure that they cover wider records, not just the acute record. And those have gone through the process at the last DDRI committee. And we're working with the SDGs Directorate to address any immediate concerns that are coming out of that audit review.
Thank you, Andrew. And any questions? Is there any points either for well, on any of the alerts or the other aspects of the report? They're comprehensive. Okay, so we're okay to take assurance. Thank you very much. Thank you, Karen. So then we move on to quality and safety. And Steve, this is your outgoing
It is.
chair report on quality and safety then.
I agree with Jean. I'll take this one. So it was a very prolific meeting in March, and I raised these alerts orally at the last board meeting, so they'll look familiar. Just to go through them again now that they're in format. We had the Mental Health and Learning Disability Service Group highlight report, and a couple of matters arose from that. One, there were serious workforce deficiencies, especially in psychiatry. And as we have previously noted, the estate where mental health services are delivered is in very poor quality in a number of cases. And the executive lead for that is Deb and also Darren to an extent on the estate. So I don't know if you want to think about those points.
From my perspective, we're working very directly with the transformation programme, specific work stream set for capital estates, and two preliminary ones intended by my team. I'm going to chair that going forward. Options are being worked out, so coming from the board next month.
Yeah. That's good as well. That's fine. Thanks, Jen.
A comprehensive report for special purposes.
Yeah.
Yeah, thanks.
Next one was the General Dental Service access, and we've got a paper on the agenda today, so I guess we can wait for that. End of life care quality priority plan. The presenter was herself concerned that we hadn't quite got this priority right yet, and as the note says, Swansea Bay people are dying too often in the wrong place, so in the hospital environment instead of in their home. So that's something that the committee would like to see coming back to it during the next at least year, I would think. Then the right care person, right care update. We wanted to just keep the board appraised of that situation. It is unwinding at the moment, in the sense that the new measures are bedding down, and it's not yet clear to what extent it will impinge upon us. But we're keeping an eye on that. That will be reported back to the committee regularly during the course of the current year. We had an update on the maternity, on the Embrace numbers, and as you recall, so an alert there because we wanted, or the service group wanted, a minor investment in some terminals to make life easier, and during the meeting it was confirmed that that investment had been funded and would happen. And finally, we brought again to the attention of the board the fact that we're outliers in the infection prevention and control area. We have the highest incidence of C. difficile in the country, so we just wanted to keep the issue in the spotlight. There's a lot of work going on, but the board should be kept aware that this is a concerning issue. So those were the six.
On that last point, Liz, we're going to pick that up as part of the, Liz will come and pick that up in terms of HCRPC, that concept. Any other points or comments on the update? Jean, did you want to come in as the incoming chair, or the chair who's come in now?
We've had one meeting that I chaired abysmally without a computer half the time. However, some of the things that we would like to advise board on, which will be in our next board paper, is that we're having a look at the way in which we've brought things like the nationally reported incidents, because a member of our committee quite rightly raised two of the incidents that were reported. And there was insufficient information behind the report to give us satisfaction of where those incidents are being managed, how they're being managed, and what the follow-through looks like. So there were a number of reports we want to take away, have a look at construct, and perhaps come back with a different format, particularly able to demonstrate the governance around some of these aspects. The other thing that we picked up was in terms of the COVID-19, there's still an issue around the archivist. I don't know whether Hazel's got any more update on that.
Yeah, we're currently holding the position at the moment, but we are managing the situation. So any request that comes through, we are managing within timescales. So we're currently holding the position at present.
And the last piece to advise board was that Dr. Raj Krishnan came and gave us an update on the maternity and neonatal Gold Command. As we've had right the way through a comprehensive understanding that they're on top of every action now that has been highlighted from whatever avenue that's come. And the one thing that he said he was disappointed that couldn't be made public at this stage was the results of the friends and family surveys. We had a 92.5% positive, whereas the All Wales is 85%. So he felt, whilst he's closing down the reports and the command and will move to a different level of command, the learning that they are now picking up is equally as important as it was in the actions that they've already closed. So I think we all took assurance from the fact that that is being appropriately managed and is well understood by everyone. What to think of the result for us.
Any other comments, questions? Thank you very much. So we can take assurance and thank both chairs for those updates. So we now then come to performance and finance. And Pat, would you like to take the March one now? And Darren does his finance report. Then you come back in.
Yeah, there's March and April.
Yeah.
Obviously in March, our alerts were around the PFC's thoughts and level of assurance on the draft financial plan, which is on constant review and is moving. So I can update us on that after Darren's done his presentation. The other two was the committee's long-term concerns about clinically optimised patient levels, which back in March we hadn't yet seen the numbers, the benefits coming through of the work to date. We have had an update on that in the last committee in May, which was very positive about the level of work that's going on about that and the fact that there's now started to impact on the numbers, down to 211 in April. And the other alert from March was about the pace with which the CHC, the continuing healthcare transformation, the centralisation, the pace of implementation of that. And again, PFC is having an update report from Marie in June on that. It was a kind of a lack of a timeline implementation plan and the pace of that. So those are the two in March. You want me to move on to April?
Move on to it. Yeah, move on to April and then we'll ask Darren to come back on how.
Sorry, I'm just trying to find you there. In April, our concerns were about certain aspects of the performance report. Thank you. So it was on certain aspects of the performance report. Sorry about that. Right, yeah. And these were, which we felt were very static and at a poor level of performance and pretty static. One of these was
developmental disorders and access to assessment. Another was the direct admission to stroke units, and the neck of femur timely operations following the day of entry. And the other one, of course, endoscopy was one of those at the time, and mental health access to psychological therapies within 26 weeks. So those are the ones we've highlighted, and hopefully we're going to pick those up in an ongoing way in the reports that come through now, especially as we can have them as areas of concern.
I'm going to cover all of those in my updates later on, Chair, if that's okay. We can do that then.
Thanks very much. And for March and April, then we can take assurance from the work of performance and in the 2 months, and Pat will be giving us a detailed update from May after your finance. Should we hand over to you?
Yes, thank you, Jen. There are two reports before us today. One is a brief report which covers the year end, and the second report sets out the financial position for the board at month one. So if I may take the end of year report first, thank you. And just to mention that from an audit perspective, before I pick up on the numbers, the draft accounts and the analytical review of the accounts were received by Audit Committee last week. We had a thorough discussion on the content and the nature of those at that point. The final figures in this report clearly remain subject to ongoing discussion by Audit Wales. We're progressing well with the audit. We're on target to meet the deadline for the committee and board at the end of June. And I've been informed this morning that we will get that with the ISA 260, which is the audit feedback, either before or on the 11th of June, which gives us plenty of time to consider that. There are no, at this stage, no material issues being raised. As ever, there are issues of clarity and classification, but in terms of bottom line, that is not different. The page 3 of the report, number 2.2, provides the position in terms of the main 4 indicators. I'll just take us through those. So from a cash perspective, at the year end, we were targeted with holding no more than 6 million in cash, and the position was 3.44 million, so we did that. From a revenue perspective, which is obviously where the key debate has been and will continue to be, no doubt, we were issued a do not or not to exceed revenue target of a £43.7 million deficit. And at this stage, the draft reported out to is 42.5 million, which is 1.2 million better than that. That's a 2.4% deficit on the quantum spent that we described earlier in the instructions, Chair. So whilst this meets the in-year requirement in terms of our do not or not to exceed target, clearly it's not a balanced or target control total position. And also because of the overspend, that means we haven't met a 3 perspective, and I clearly need to formally report that to board today. From a capital resource limit perspective, we achieved the limit in year. We reported a very modest surplus of 61,000. That was on a £54 million capital programme last year, which is a 0.1% surplus on that. We've also managed to sustain that over 3 years. We have met the duty in terms of the capital resource. Finally, on a duty to settle invoices, 95% or more within 30 days, based on number of invoices rather than value, we achieved 95.04%. That, which met the target, and we paid 283,000 invoices last year in doing so. And if there were a better way to pay those invoices or less invoices, we can produce a better. But that's key commitment for us in terms of our creditors. So I'm asking the board to discuss the position today, Chair, acknowledge it, and obviously acknowledge the time frame and the process of audit through to the end of the month.
Yes, thank you very much. So any comments, questions on the year end position? So I'm sure we would like to say thank you to all the staff involved in enabling us to come in at that 42.5 million deficit of the year. Phenomenal across the organisation. So we want to acknowledge our thanks.
Absolutely, yeah. And considering the profile that most of that was delivered in the final second half of the year, absolutely, John. Thank you.
So we can acknowledge all the key messages that Darren has set out in the report around the cash balance, the capital draft outturn position, PSPP position, etc. And that we have actually not met our duty to break even over the 3-year period. Well, we did, but we failed to achieve the same for the RRL. So we did it for the CRL, but not for RRL. Thank you. So, Darren, can we move on then to 25-26 and as well?
Thank you, Chair. So this report obviously sets up month one, and it's set against the current submitted health board plan. We know that plan is submitted, not approved, and we also know, and this is ongoing discussion with us, going to remain unsupported and unacceptable to government, as it does to ourselves. But we need to recognise that language. Page 4 of the report reminds us of the construct of that plan under section 3, and the table at the top of that page just reminds us that even that level of deficit is predicated on delivery of a 5% savings target of 55.4 million, which I'll touch on as I go through. Page 4 of the report shows that the health board recorded an in-month deficit of 9.0003 million in month 1, and that's 4.1 million off the plan. As on the table at the top, page 5 of the report shows that whilst there are some operational variances across the piece, delegated budgets, it's very fundamentally the lack of savings delivery which is driving the challenge in the financial performance and the incredibly challenging position we see in month 1. It's also important to remind the board that the budget strategy for 25-26 largely addressed the underlying deficits in delegated budgets, and therefore with the delivery of savings targets out, every delegated budget as the health board to break even. Clearly the variance being driven by the savings is part of that challenge. And then we need to go further to go better than the 15.7 million deficit as focused. And the chart at the bottom of page 5 just gives some illustrations of the position at month 1 and what that means in terms of future months. We now need to be better than planned in future months. The savings, which is the flip side of that, shows the very modest level of savings identified in period 1, which means we now need to find more savings in every future. In terms of page 6 of the report, there's a detailed presentation of the key drivers of the position, which we use consistently through the year, and I've presented this to independent members and some aspects of the Performance and Finance Committee, but clearly at board level it's important that I show this in its entirety. Largely, the majority of budgets are within the tolerance that I would expect, but it is worth highlighting, and we did touch on this earlier, that there are still some adult mental health placements that are outside of our bed base, which are driving a spend variance of 660,000 in month 1, and we list 22 individuals. I understand that's down to 14 now, so there's work going on there. That's still 14 too many. We need to work on that from a quality care perspective and from a finance perspective. But clearly, the second section of that report, reading across the page, just gives you a sense of where the savings deficits are, the 4.16 million, and that's across the majority of the areas of the delegated position across the board. Over the page, you'll see then the position in terms of savings. That's in the section 5.1. And what that demonstrates is the 12th phased savings budget would require us to save 4.62 million a month. And we achieved 10% of that in month only 60,000. And therein lies a significant challenge for us and a matter of significant concern. We'll discuss that. I'm sure we'll discuss again. In terms of plans from here on in, the revised accountability process that we have this year, which is stronger, requires detailed plans to be received by tomorrow. That's a condition of the accountability issues and the accountability requirements we've issued. And Abigail and myself are working through, and what some immediate next steps will be as a result of a month 1 would be the lack of emergence of further significant savings in the last 4 weeks since we reported. And some of those things will include the critical review of the expenditure plans that we will get tomorrow and savings plans. Further mitigations are discussed with my executive colleagues in the last couple of days. We'll discuss those at the tech team on Monday, bring us forward. Performance and Finance Committee, without stealing Pat's comments later, we need to refine support in that of the big ticket areas and get a sense of what those are in terms of workforce redesign, variable pay, procurement, continuing healthcare, medicines and urgent emergency care. And again, we need to hold a special session probably early July. We've got a date penciled in for that to have a very thorough scrutiny session on savings plans and where we can come. And later on today's agenda, and again you've touched on it, Chair, there's an updated performance and accountability framework to come before the board. That will go live into these discussions, so we'll be using that to help manage some of the escalation support required to do so. There are no cash or capital requirements to report in month 1, but those headings are there just to show that there's a nil return for now. We'll bring those forward as the year progresses. And reflecting all of that, the risk levels of recognition is at 25 at this stage discussion. And as is usual at the start of the financial year, the capital risk can be increased to 20. As we get certainty on allocations for the year, we will manage that. If there is a balanced plan available, there's limited contingency, that's why the money for the capitalist. There's a lot of analytical detail in the report that follows, but just wanted to get across the the scale of challenge, particularly around the savings and the need for us to do more faster to get through that. And don't go through all the recommendations, Chair, you've got Paul's there.
Thank you, Darren. Well, I'll ask Pat as Chair of Performance and Finance Committee, because the full board relies on the level of assurance that Performance and Finance can say we can take from the current position. So, Pat, would you like to take us through that, please?
Yeah, sure. We had a discussion on this, a detailed discussion with you this week in the meeting, and members of the committee are very concerned, obviously, about the overall financial position in month one for by 4.1 million. The risk around the savings delivery, so just over 17 million, 17.9 million at month two, but over 75% of that is in red status. And despite all the successful work on reducing agency spend, we've still got a variable pay spend of just in excess of 5 million, which is very much similar to April in 24, which is worrying. So the big concern is about the pace of delivery of robust plans for the £55 million savings that we have to deliver in the current year, and the need really for that to be a rolling programme. We did discuss possible ways that could be strengthened, that approach could be strengthened. And whilst we recognise and appreciated the recovery and sustainability programme's wider remit in terms of a long-term sustainability of service delivery, we think there is now a need for 100% focus on recurrent financial savings delivery in this year and beyond, with an imperative really to increase the pace of those plans coming through. We thought that there should now be a short list of savings themes. There's 5 or 6 of those really that have real potential to make bottom line recurrent financial savings. And that each of these themes or work streams now really need clear leadership from an executive senior responsible officer, with a remit to develop savings solutions in full collaboration with the service group directorates, the directorates and other kind of clinical experts, etc., as appropriate. They really need to be set a savings target, and they're going to need the redirection of support into them, so they make sure they've got finance, HR, data analysis, project management support that they need really to deliver that at the pace they need. The executive saving themes and the service groups are reporting to PFC on a monthly basis, but when we looked at that timetable, it didn't really give us the level of assurance we need early enough in the year. So this is why we were looking at having some kind of star chamber type event, a day event in early July, so that exec directors and service groups can kind of jointly deliver their financial savings to, I think, PFC members, obviously, but other members of the board that they want to attend. In terms of that meeting, there were some positives really in assurance as well. We had raised back in March the need to improve the internal performance monitoring and escalation. This has now been actioned by Darren and his team, and we've got the new performance and accountability framework here today. It was well received, some minor amendments that are going to go through, but it was well received by the committee. We thought it's robust, it's aligned with the Welsh Government escalation framework, and we thought it would improve accountability. So we're really endorsing that for approval here today. And we also took assurance from the fact that the planned procurement of external advisors is currently underway. So we thought that was positive as well.
What's the timeline for that last point, Darren, the procurement?
So just looking at it, Chair, we're holding a date on the 10th of June to see shortlisted providers. Basically, this will be a partnership with the change agency as well as an analytical agency as well. And we're looking to get the contract in place certainly before the end of the month, maybe a week before the end of June. So we're moving as quick as we can to get that in place, given a lot is taken to get a specification signed off with colleagues elsewhere.
So I'll open it up more widely for comment. And Nuria, I know that you want to come in.
Thank you, Darren. Darren, I had a couple of comments. One is in relation to month one, how did we do against our actual expectation for the month, given that we know we were starting the year without a full set of savings plans and what is our confidence in our ability to turn things around over the rest of the year? And I just wanted to clarify the month's 12th position on the table. I think there might be an error in table 2 in relation to savings. So can you just explain to us the Morriston figure in particular, delivering in terms of savings? I think it says 8,154 from memory. I'm trying to download my paper, but it's not downloading for me. But then it says it delivered 11,720 million of recurrent savings. Can you just explain that to us?
Do you want me to read
Do that, yeah. Do that.
Yes, I've got the table before me, Neria. The figures for Morriston are in your forecast was the 8.1454 million, and they were 5.6 million off that. So only delivered 2.5 million in year, forecast of 8.1. And the 11.72 million you quoted was the forecast recurrent aspect of those in-year savings, which were more substantially delivered with only 2 million shortfall from those. So one is in-year and variance from plan. The second is recurrent impact of that value and variance from the plan recurrently.
I hope that's a helpful clarification for 24-25, but your substantive point relates to the level of confidence in respect of the savings that Pat was outlining around the 55 million. So that's a point in support of Pat's point from the committee. Yeah.
Yeah.
Rena.
Yeah, we were just discussing informally the fact that at the beginning of the year, we've got a savings target and we basically attribute it by 12, so we basically say, now in reality, if we had a more detailed savings analysis of when the savings are going to come through in the year, then in a way, it would enable us to have a better understanding of whether we're on track or not. Because at the moment, we don't have that, do we, Darren? We just haven't got that. So I really do feel it is important that we have some kind of more granular detail where the savings that we're aiming to achieve are coming from. And I totally agree with Pat and in terms of the PFC comments that we need to prioritise and work on a small number that are likely to give us the savings we need, not, if you like, use the resource in a scattergun approach and we won't get there. So I do feel we need to do that. But I certainly do think if we have that kind of analysis, it will enable us to have a better understanding of whether we're on track each month, as opposed to at the moment using an arbitrary figure, which doesn't actually give us really the assurance we need in terms of where we are.
Sure, we're going to come back to profiling as we pick that up. I've got Andrew, then Steve.
Yeah, I think my point is largely backing up what Rena is saying. Just trying to work through the figures, just to identify where we are on the savings, and if I've got it right, then I may not have. The levels of savings identified for month 1 was pretty small, and we probably exceeded it in terms of the actual saving was bigger than the identified savings. If I'm right here. So that came back then. I was thinking about how this is working through my brain, and it's probably the same point as you're making. It would be useful to have that sort of profile, even if it was a different colour on that yellow graph that identified the bit that's been identified, because in a sense, people haven't failed to meet the target. They failed to identify the target.
We haven't got a plan. It's the difference between deliverability and actually identifying the savings in the first place, which is the conversation we had yesterday.
Yeah, because in a sense, or you're beating it or not beating it, but you haven't got it, if you know.
Yeah.
You know, so there's a bit about that, and I just wonder whether there's a better way of representing that gives us a bit more idea about whether we have identified the savings, because that's the problem before the second problem is there.
It doesn't matter how you profile what you don't have.
Yes,
Yeah.
that's not it. We haven't got a plan for savings.
Yeah. Steve, please come in.
Yeah, so a few points. First, I support Pat's proposal to have a special PFC meeting in July. We need to hear directly from the executives responsible what they're going to do and when they're going to do it. The timeline that was proposed to us had some of these execs coming see the committee in January, which is clearly far too late. So it's got to be done. It's got to be done sooner rather than later. Just on the mental health out of area placements, Aaron, you're right, it was down to 14, but I was there yesterday at Kevin Coyd, and after the bank holiday, it's back up to 22 again. And you know, you can do the maths. That is potentially an £8 million spend just on that one line, overspend just on that one line over the year. So that needs to be got hold of. In one of the papers that we discussed back, I think in March, in anticipation of Q1 looking under pressure, you said that there would be a number of mitigations that you had in mind to put into place should that eventuality occur. Well, I would suggest it is occurring. So I wonder what those mitigations are and when they might be seen. So rather than just say, okay, we'll accelerate the savings or we'll catch up on the savings, what else can we do now to start putting some of that money back? And I think that's what I would say.
Steve, any other comments, questions, Jean?
I have mentioned this before, and it's been touched on this morning, that I'm really uncomfortable with this divisibility by 12, because as we've said, I guess I can explain it best in retail, where we use the last quarter of the year as the golden quarter because it's Christmas. And I guess for us, it's still a golden quarter for all the wrong reasons. But there are times throughout the year when we do get a different footfall, as it were. And I'm just concerned that we start off the year in an unrealistic position. So I just would like that comfort that the way we're profiling is actually appropriate the whole year.
John, do you want to come back on this question of profiling?
Yes, basically. I think, and that's having a collapse in the executive schemes into one conversation rather than spread them through is very sage, and we should do that. I will pick up the conversation with mental health to see if there are ways we can render this for patient perspectives. And in terms of mitigations, there is a list doing the rounds from executive colleagues at the moment, to my left, Exhibit A. And I've had conversations directly with a number of colleagues, particularly on variable pay, which have been productive and which we will discuss together. You know, I think in a more instructive and participative way in the organisation, because we've been very supportive at the moment, but I think we need to be more direct in terms of expectations. So the profile one is an interesting one, and I think I need to separate budgetary discipline from plan analysis and plan profiling. When I stood up in September 2024 and said next year's plan is going to be really difficult, we need to start looking at savings, never really meant that, because I mean, savings in this year. Had we arrived on the 1st of April with £55.4 million worth of savings in a shape across the year, I've been very comfortable to profile the savings budget to meet the plan because we had the plan. At this stage, because we don't have a plan that meets the 55.4, discipline is the 12th is actually the way to show the organisation the level of risk that we're carrying, because the variance is a true variance. There were no savings in that